So, good afternoon to all the participants and very warm welcome to today's session. And so far we have learned about the clinical manifestation management of mild moderate cases of COVID and how to give oxygen therapy and how to do non-invasive ventilation. So today's session is focused on the mechanical ventilation. So we know that we have a heterogeneous group of participants. So it's very difficult to teach according to all of you, but we will try to keep the thing simple and we'll try to stick to the basics of mechanical ventilation in children. So I think we should start now. So I invite our first speaker, Dr. Manisha Maurya. She's Associate Professor of Pediatrics at LMNMC Prayagraj, and she will be talking about the basic terminology of invasive ventilation. So welcome, Dr. Manisha.
Thank you, ma'am. Thank you very much. On the third day of pediatric COVID training, we will be first discussing on the basic terminology of invasive ventilation. In the first 2 days, we all must have studied what are the basics management of COVID and oxygen therapy. Now we'll be learning about the invasive ventilation. For learning in the invasive ventilation, it is very important to know what are the basic terminologies which are used and to set and monitor during a invasive ventilation. So we'll be discussing this in this session. Now the specific learning objectives are concepts of basic parameters of mechanical ventilation, parameters that control oxygen, parameters that control ventilation, and the video demonstration to how to set up a ventilator. Now first we will be discussing the respiratory rate or frequency. The respiratory rate or the frequency is set on a ventilator. It is the number of breaths a ventilator will deliver. The initial rate which we set is according to the physiological rate for that age. So if we are, for example, if we are setting a respiratory rate for a neonate, it may be around 30 to 40 as the physiological respiratory rate of a neonate is towards the higher side. And if we are setting the respiratory rate of a infant, it may be around 25 to 30. For children less than 5 years, it's around 20 to 25. For above, we will be setting around 18 to 20. Then in adults, we all know 12 to 14 is the usual physiological respiratory rate. But this is the initial setting. And since respiratory rate determines the minute ventilation, which is product of tidal volume and the respiratory rate, it determines the carbon dioxide elimination. So whenever we are setting a respiratory rate, our intention is to provide a eucapnic ventilation, that is to have a normal PaCO2 ventilation. So titration has to be done after seeing the PaCO2 level. Whenever in ABG, the PaCO2 level of a patient is high and is going beyond the permissive hypercarbia, that is if it is more than 55, or if the hypercarbia, the PaO2 level, the carbon dioxide level is such that it is causing the decrease in pH, then we will have to manipulate respiratory rate so as to provide eucapnic, that is to have a normal PaCO2 level and a normal ventilation. So the initial rate is set according to the physiological rate and titration is done according to the PaCO2 level. So whenever PaCO2 level is going very high, which is causing respiratory acidosis, we will have to increase the respiratory rate so that carbon dioxide washout occurs. Now the next setting is the tidal volume. Tidal volume is usually set in a volume control mode. It is the volume of air delivered to a patient during a ventilatory breath. It is preset at the volume
Dr.
control
Manisha?
mode. Yes, ma'am.
Dr. Manisha, so there is a request to go a little bit slow.
Okay, ma'am. Okay, ma'am. I will be.
It is from the participant.
Okay, ma'am. Okay, thank you. So the tidal volume, I think, should I have to repeat respiratory rate or frequency?
No, you can continue from here.
Now the next setting which we set on a ventilator is tidal volume. That is, we set on a tidal volume is set in a volume control mode. We will be discussing more details about the modes in the coming session. There are two basic modes, the volume control mode and the pressure control mode. In volume control mode, we set a tidal volume. In a pressure control mode, we set peak inspiratory pressure. In a volume control mode, when we set a tidal volume, we usually monitor the pressures. And in a pressure control mode, where we set the peak inspiratory pressure, we monitor the tidal volume. So whenever in a volume control mode, we are setting the tidal volume, we have to monitor the peak inspiratory pressure, or the pressures has to be monitored so that it doesn't go beyond the required, as it may cause barotrauma. So in a volume control mode, the initial setting which we set for a tidal volume is around 6 to 8 ml per kg. In case of COVID pneumonia or COVID ARDS, where this mechanical ventilation is required, the initial tidal volume is set around in the lower range, that is about 6 ml per kg, as high tidal volume in a severely damaged lung, as in case of ARDS, may cause pressure damage and may cause barotrauma. So we have to start with a lower tidal volume, that is 6 ml per kg. Tidal volume is also determinant of minute ventilation, that is the product of tidal volume and the respiratory rate is minute ventilation, that is amount of air the patient is delivered in 1 minute, that is the ventilation. So this tidal volume, whenever we are setting in a pressure control mode, we have to keep monitoring the pressure. And in a volume control mode, we have to keep monitoring the pressure. And if we are setting, if we have used a pressure control mode, we always have to monitor the tidal volume in the ventilatory display unit. The tidal, setting which we don't set on a ventilator is determined by the ventilator, by its sensor, and is displayed on the ventilatory display unit. So in a volume control mode, the pressures are variable. In a pressure control mode, the tidal volume is variable. And this tidal volume or this tidal volume is variable according to the lung compliance and the airway resistance. The next setting which we set on a ventilator is FiO2, that is fraction of oxygen in the inspired air gas mixture. So as we know that we set the FiO2 from 21% to 100%. So that is from atmospheric pressure to 100% oxygen. And FiO2 is mainly used to improve the oxygenation status. We have to adjust this value according to the PaO2 and SpO2 level so as to keep both this in the acceptable range. In the previous session, in the last 2 days, we all must have studied the acceptable range of PaO2 is around 92 to 94 and PaO2 is around 60 to 80, and the acceptable range of SpO2 is 92 to 94. So we don't have to be very aggressive in setting this FiO2. As aggressive management is not required, we just have to have a acceptable range. So we don't require a SpO2 of around 95 to 96 or 100%. We want to have a SpO2 of around 92 to 94%. And by seeing this, we have to set the FiO2 level, as FiO2 increases the oxygenation. High FiO2 more than 60% may not be good for the patient. So whenever we are starting the ventilation, invasive ventilation, when the patient condition is not good, we can start from 100%. But as the patient condition improves, we have to try to decrease the FiO2 to below 60%. So we have always remember that FiO2 more than 60% may cause oxygen-related toxicity. So once the patient has stabilized by other maneuvers like pressures or tidal volume, we just have to decrease the FiO2 to less than 60%. And FiO2 is titrated so as to keep PaO2 and SpO2 at the acceptable range. Now the next value which we set on a ventilator, this is very important value, that is PEEP. It is positive end expiratory pressure, or it is the pressure that is maintained at the end of expiration. The main function of PEEP is it improves ventilation perfusion matching and oxygenation by decreasing the intrapulmonary shunt. Intrapulmonary shunt is the amount of blood which is coming from the heart to the lungs for ventilation again goes to the heart without being oxygenated. So whenever the intrapulmonary shunt is more than 15% or 20%, there is severe decrease in oxygenation status of the patient. So what does PEEP does? PEEP decreases the intrapulmonary shunt by improving the ventilation and decreasing the ventilation perfusion mismatch, and thus PEEP improves the oxygenation of the patient. The second function of PEEP is to increase the functional residual capacity, FRC. FRC is the amount of air that is left in the lung after normal exhalation. So there has to be some air in the lung after normal exhalation so that all the alveoli may not close, and during each inspiration, more pressures are not required to expand the alveoli. So the function of PEEP is to increase the FRC. Thus, it recruits the previously collapsed alveoli in a diseased lung and thus improves the lung compliance, and thus it increases the oxygenation. Now let us see this diagram. We see, where is my cursor? This is the first diagram. This is the alveoli, which is partially collapsed, in which we have delivered a low PEEP, or there is a low PEEP. So we can see here, this in a collapsed alveoli, ventilation is not proper, but perfusion is good. So this is a case of a ventilation perfusion mismatching when PEEP is not adequate or low PEEP has been given. Now see this diagram. In this, we can see that it is over-distended alveoli. This over-distended alveoli is because of very high PEEP, or maybe because of some hyperinflated lungs in a disease condition. So this very high PEEP causes the compression of this vessels, this perfusion. So perfusion is hampered. So although ventilation is good, perfusion is hampered. So this is also a case of ventilation perfusion mismatching. Now let us see this. This is a optimally open alveoli. We have given optimal PEEP. So in this, both ventilation and perfusion is good. So we have matched ventilation and perfusion by giving optimal PEEP. So PEEP is very good mechanism for improving the oxygenation of a patient. But while setting a PEEP, we have to keep in mind that over distension of the PEEP by setting a high PEEP may cause over distended lung, and over distended lung may decrease the venous return to the heart, as all the venous return goes from that lung area, and this decrease in venous return to the heart will cause decrease in cardiac output, and decrease in cardiac output may cause hemodynamic instability or decrease in blood pressure. So very high PEEP should be avoided, and while setting a PEEP, we have to keep monitoring the blood pressure. The second problem of setting a high PEEP is air leaks. So when we are setting a very high PEEP in a damaged alveoli, which is already damaged because of the disease pathology, it may cause air leaks by bursting of the alveoli, and this air leaks may lead to pneumothorax or pneumomediastinum, which may further compromise the ventilation of the patient. So while setting PEEP, these things have to be kept in mind. The initial setting of PEEP is in children is 3 to 5 centimeters of water. In a disease condition, like in a ARDS pneumonia in a child with COVID, we may start with a high PEEP, that is 8 centimeters of water. So the next is PIP, that is peak inspiratory pressure. It is the highest pressure which is reached during the inspiratory phase. As we have discussed earlier, the tidal volume is basically used in volume control mode, and PIP is used in a pressure control mode. So PIP is the maximum pressure which is delivered to the patient in one inspiratory phase. PIP improves the oxygenation, and high PIP, as it is a pressure, may cause air leaks and barotrauma, increase sometimes. In a volume control mode, we always have to monitor the PIP, as PIP is variable in a volume control mode. We don't set a PIP in that, and we have to keep on monitoring the PIP in a volume control mode, as it is variable according to the lung compliance and the airway resistance. So PIP in a volume control mode, if we are seeing that there is an increase in PIP, then it may be because of airway resistance, and the airway resistance can be because of secretions, bronchospasm, or mucus plug. And whenever we are finding this, a sudden increase in PIP, we have to think of airway resistance. We have to go and do suction for secretion. And if we are suspecting bronchospasm, we may have to nebulize the child. And for mucus plug, we may have to nebulize the child along with suction with N-acetylcysteine. So PIP, the initial setting of a PIP is 18 to 20 centimeters of water. Now let us see this diagram. This can easily differentiate between PIP and PEEP. As we can see, PEEP is the maximum pressure which is reached in one breath, and PEEP, that is positive end expiratory pressure, is the baseline pressure which is maintained throughout the cycle. This graph can be seen on a ventilatory display unit. Now next is the plateau pressure. Plateau pressure, this pressure we are not setting either in a volume control or in a pressure control. We just have to monitor this pressure, that is plateau pressure or P plateau. Plateau pressure is the alveolar distending pressure, or the pressure applied by the ventilator to small airways or alveoli. So for example, if we have given a PIP in one breath, the maximum pressure which is delivered by the ventilator in the breath, as it reaches the alveoli, because of some airway resistance or lung compliance, some pressure is decreased. So the pressure which is coming up to the alveoli is called the P plateau, and P plateau reflects the lung compliance. Compliance is the distensibility of the lung. So lung compliance, P plateau reflects the lung compliance, and usually what we monitor the P plateau on a ventilator display unit, it has to be kept below 30 centimeters of water. So since we are not setting this P plateau level, we have to derive this P plateau level. We derive the P plateau level by doing inspiratory hole maneuvers. Inspiratory hole maneuvers are there on the ventilatory display unit. You may find a direct button on the ventilatory panel, or this inspiratory hole maneuver button can be seen on the setting section or the tool section. So we have to keep on monitoring the P plateau level. We just go and press the button of inspiratory hole maneuver for 0.5 seconds, and we will get the P plateau on the ventilatory display unit. So in this diagram, we can easily see what is P plateau. This is also a pressure time graph. We have given an inspiratory hold of around 0.5 seconds, and this is the P plateau. That is when we are giving a pressure, peak pressure is given because of some airway resistance or compliance of the lung, the pressure which is coming up to the alveoli, this is P plateau, and it is derived by doing a inspiratory hold. Inspiratory hold is buttons are there either directly on the ventilatory display unit, or it may be in the tool section, or it may be on the setting section. We have to go and find. Sometimes in value section, we may directly see the P plateau level. These P plateau level are false P plateau level. We always have to have a inspiratory hold to get a proper P plateau level. So we just have to find the P plateau on the ventilatory display unit, hold it for 0.5 seconds, get the P plateau, monitor it. It should not go beyond 30 centimeters of water. In this diagram, we are seeing that the difference between P peak and P plateau. If we are finding a very large difference, more than 10 mm, then it may be because of increased resistance in the airway, maybe because of some blockage or some bronchospasm. So that has to be kept in mind. There is some decrease in value of P plateau from P peak, but it should not be very large difference between P peak and P plateau. And in a volume control mode, if we are finding that P peak and P plateau both have risen very high, that indicates that the lung compliance is poor. And in poor lung compliance, we always have to keep the pressures limited so that it may not damage the lung and may not cause barotrauma. Now, the next setting is mean airway pressure. Mean airway pressure is the average pressure in the respiratory passage during the ventilation, or it may also be said as the area under the pressure time graph. It is determined by PIP, PEEP, ventilatory rate, and TI, and the typical map is 5 to 20 centimeters of water. We usually don't set the map on the ventilator. We get this value on the ventilator display unit. The ventilator derives it, or we can derive it by the formula TI multiplied by PIP plus TE multiplied by P upon TI plus TE. And this can be set. The typical map is around 5 to 20 centimeters of water. So whenever we are ventilating a child, we have to go and see whether the patient is getting adequate map or not. So we have to see the ventilatory display unit, the value section, from where we will get the map, or if it is not there, we can calculate the map by the formula. And MAP is the best method of increasing the oxygenation in a patient. And since MAP is determined by the 5 parameters, that is the area under the pressure time graph. This is a blue color, we can see. And this area can be increased by either the increasing the inspiratory flow, or this area can be increased by increasing the peak pressure or the PIP, or this area can be increased by increasing the inspiratory time, or this area can be increased by increasing the PEEP, that is positive and expiratory pressure, or we can increase the respiratory rate. So if we want to increase the oxygenation, we have to increase the MAP, and MAP can be increased by increasing either of these 5 parameters. The best among these is PEEP, that is positive and expiratory pressure. Now let us see the next value, that is peak inspiratory flow rate. That is, it is tidal volume upon TI, or it can be said the maximum speed at which the set tidal volume is delivered on the ventilator. It is expressed in liter per minute. Since it is the maximum speed, it determines the inspiratory time also. High inspiratory flow rate, faster peak inspiratory pressure is reached, and the shorter is the inspiration. And if we set a lower flow rate, then we will have a longer inspiration. So this peak inspiratory flow rate, this button is usually found in volume control mode, and in some of the ventilator we may not find this button, and in ventilator by default it is set around 60 liters per minute. It may range from 30 to 100 liters per minute, and it can we can manipulate it so as to have a change in inspiratory time. The next is IE ratio. IE ratio is the ratio of inspiration upon expiration. Normal IE ratio is 1:2. So this IE ratio is basically used to set the inspiratory time and expiratory time. And we have to keep this ratio as physiological as possible. That is, the inspiratory time which we set on a patient has to be according to the physiological inspiratory time of that patient. For example, if we are setting an inspiratory time of a newborn, then the inspiratory time will be around 0.3 to 0.4 seconds. Since the respiratory rate of a newborn is physiologically high, the inspiratory time is towards the lower second. So for a newborn, the inspiratory time may be around 0.3 to 0.4 seconds. For an infant less than 1 year, the inspiratory time is around 0.4 to 0.6 seconds. For a child less than 5 years, inspiratory time is 0.4 to 0.6 seconds. For a child above more than 5 years, it is around 0.8 to 0.6 to 0.8 seconds. And older children, adolescents, and adults, it's around 0.8 to 1 or 1 to 1.2 seconds, as we are setting in adults. So if you are not able to remember these physiological inspiratory time, we have to go and see the IE ratio. And whenever we are setting the inspiratory time and the expiratory time, we have to keep so as the inspiratory and expiratory ratio is 1:2. Sometimes we may have to increase the oxygenation status of the patient. For that, we can increase the inspiratory time. As we have seen in the previous slide, inspiratory time increases the MAP and MAP increases the oxygenation. So for improving the oxygenation, we may have to increase the inspiratory time so that this value may go up to 1:2 also for increasing the oxygenation status. But when we are increasing the inspiratory time, we have to remember that increase in inspiratory time will cause carbon dioxide elimination, will decrease in carbon dioxide elimination and may cause air trapping also. So this thing has to be kept in mind, and reverse ratio should always be avoided. And sometimes we may have to have a proper ventilation. We may have to have a carbon dioxide washout, as in cases of some obstructive airway disease and in bronchial asthma, and some improper ventilation, as in case of GBS. We may have to have a proper carbon dioxide washout. For that, we can increase the expiratory time and have the IE ratio of 1:3 or 1:4 also. But while setting the expiratory time, increasing the expiratory time, we must remember that increasing the expiratory time may cause atelectasis also, as it decreases at this process the more air to wash out from the lung. So IE ratio is just a help to set the inspiratory time and the expiratory time, and we try to keep IE ratio around 1:2. 2 less TI in a volume control mode where we set a tidal volume. So the tidal volume will be delivered too quickly, which may result in high pressure delivered being too quickly. So this thing has to be kept in mind. And too long TI will limit the respiratory rate, resulting in hypercapnia, as we have discussed earlier, may increase the carbon dioxide also. Now let us see the phase variable. There are 3 phase variables upon which the ventilator works. These variables are trigger. Now see this diagram. This is trigger. Trigger is what initiates the ventilation, what initiates the breath, that is what causes the inspiration to begin. Now this is B, is limit from here to here, is what regulates the gas flow. For example, if we have limited a pressure, the pressure will not go beyond the limit pressure, that is PIP. If we have set 20, then the PIP will not go beyond 20 throughout the cycle. So this is limit. This is limit. And see what causes N, breath to end. This is cycle. So in this diagram, we can easily see trigger, limit from here to here. And this is cycle, what causes breath to end and start exhalation to begin. Now the ventilator will stop delivering the pressures or volume, whichever we have set, and allow the patient to exhale. Now let us see one by one. Trigger. Trigger is what determines the start of inspiration. It is of 3 types: time trigger, pressure trigger, and flow trigger. Time trigger. Time trigger is the breath is delivered once a preset time has elapsed. For example, in a continuous mandatory ventilation, if we have set a frequency of around 20, then the ventilator will deliver each breath at every 3 seconds. So it is machine triggered. Time triggered is machine triggered. The next is pressure triggered. When the ventilator senses the patient's inspiratory effort in the form of decrease in baseline pressure. As we all know that when we do inspiration, there is negative pressure created in the lung. So this decrease in baseline pressure, the patient's effort is detected by the ventilator by decrease in baseline pressure, and now ventilator helps by assisting that effort. So this is pressure trigger, and next is the flow trigger. Now in this, ventilator senses the patient inspiratory effort by sensing the decrease in baseline flow. The decrease in baseline flow when the expiration, at the end of expiration, there is decrease in baseline flow, and in the initially the patient start inspiration. So or ventilator can directly sense the inspiratory flow from the sensor at the patient airway opening. So the flow sensor and the pressure trigger. Both these are triggers are patient trigger. Patient initiates the breath and ventilator senses the patient's effort either in the form of decrease in baseline pressure or in the form of decrease in baseline flow. So both these are patient trigger, and the time triggered is machine trigger. That is, machine delivers as the time is elapsed. The next variable is limit, what regulates the gas flow during the breath. If a variable, for example, pressure, flow or volume. For example, if we have set a tidal volume of around 250, the ventilator will provide the tidal volume throughout the breath cycle. The volume will not go beyond 250. So we have a limit variable of volume of around 250. So ventilator will deliver the breath. The breath will be delivered continuously till the inspiratory time, and the limit variable will not be allowed to rise above the preset value. That is, if we have set a tidal volume of around 250, it will not go beyond 250. If we have set a PIP of around 20, it will not go around beyond 20 throughout the breath. So breath delivery will continue, but the variable will be set at a preset value. So again, we can see this diagram. This is B is limit. Limit, that is, throughout the cycle, the variable which is we have preset as a limit. Either it can be pressure, it can be flow or a volume. Throughout the breath, that limit variable will not go. Now next is cycle. What ends the inspiration? This variable is used as a feedback signal by the ventilator to end the inspiratory flow delivery, which then now allows exhalation to begin. So cycle can be also of three types: volume cycle, pressure cycle or time cycle. Volume cycle is inspiration ends when a preset tidal volume has been delivered. For example, if we have set a tidal volume of around 300, then when the tidal volume of 300 has been delivered to the patient, exhalation will start. Or if we have set in pressure cycle, inspiration ends when a specific airway pressure is achieved. For example, if we have set a PIP of around 25, so after the airway pressure of 25 has been reached, the ventilator will, inspiration will stop and exhalation will begin. And the third one is time cycle, which is most commonly used in pediatric ventilators, is the inspiration ends when a preset time has been elapsed. That is, if we have set a inspiratory time of about 0.6 second, the inspiration will end after 0.6 second and the exhalation will start after 0.6 seconds. Most of the pediatric ventilators are time cycled and flow triggered. That is, time cycle, if we see after particular time, after particular inspiratory time, for example, if we have set 0.2, 0.4 or 0.6 seconds, after that inspiratory time, the exhalation will start. That is, cycling will start. And the flow trigger, the patient ventilator senses the patient inspiratory effort in the form of inspiratory flow rate, either directly from the sensor at the ET tube or decreasing baseline flow. So the pediatric ventilator basically works upon time cycle and flow trigger. Now, all these parameters are used for practical use. So what are the practical applications of these parameters? Either we have to increase the oxygenation or we have to improve the PaO2 level. In the yesterday, we all have studied what is PaO2, which is monitored in the ABG for knowing the oxygenation status of the patient. So whenever there is decrease in oxygenation, as in COVID ARDS or COVID pneumonia, then excuse me. So whenever we have to improve the oxygenation status of a patient, as in case of pneumonia or ARDS in which the lungs are damaged, the oxygenation is not proper, so has to have a normal PaO2 level to the acceptable range, maybe around 60 to 80 centimeters of water. Either we can increase the mean airway pressure or we can increase the fraction of oxygen, FiO2. And the best among these is MAP. And for MAP, as we have discussed in the previous slide, either we can increase the flow rate, or we can increase the inspiratory time, PIP, PEEP, or respiratory rate. And the best among these is PEEP. So for improving the oxygenation status, two of these things can be used, and MAP is best. And FiO2, when we are improving the oxygenation by FiO2, we always have to keep in mind that FiO2 more than 60% may not be good for the patient, may cause oxygen-related toxicity. This thing has to be kept in mind. And the parameters that determine ventilation, that is PaCO2 level in cases in which ventilation is not proper, as in case of neuromuscular blockage, or the CNS depression, or patient fatigue, or patient apnea, where ventilation may not be proper. There is increase in carbon dioxide level in the ABG. Then this increase in carbon dioxide level, if it is beyond the acceptable range, then either we can increase the tidal volume, or we can increase the respiratory rate. The best among this is respiratory rate, and we don't usually use tidal volume to improve the ventilation by increasing the tidal volume, pressures also increase, and it may not be good for the patient. Now we'll be seeing the videos at the end. Now this is the simple diagram of a ventilator. We can see that this is the this is the oxygenation, central supply oxygenation. The ventilator is connected to the central oxygen supply and to the central compressed air supply. And in the ventilator, there is a blender in which both air and oxygen is blended, and the desired FiO2, which we want to have, is obtained by this mixture. Either we can have 60% or 50%. And so air is very important. In some of the new ventilator, this central air line may not be there, and there is inbuilt compressor, which is here. So this compressor gives the compressed air to the ventilator. So the compressed air is there, and now this is the ventilator in which various buttons are there and various control panels are there. And then this is the electric supply. We have to give electric supply to the ventilator, to the UPS, and to the compressor. And whenever we are finding any problem in the ventilator, first of all, we have to go and see whether the electric supply is given to all the three instruments, that is the ventilator, the UPS, and the compressor. So this thing is very important, as we just have to have we can have many problems, we can face many problems if we are not giving a proper electric supply, and this is very common mistake. Now this is the breathing circuit. This is inspiratory limb and this is expiratory limb. So both these limbs are there. This is a water trap. This is flow sensor, which is connected to the ventilator. And this is HME filter, that is heat and moisture exchange filter. This HME filter is used when we are not using a humidifier. Here we have to connect the humidifier. And if we are not using humidifier, we may have to use the HME filter, which gives heat and moisture exchange filter. And while setting this HME filter, we have to keep in mind that this should be of adequate size. Pediatric size has to be used. And since if we are using a large HME filter, it may cause increase in dead space. And this is a test lung, which is provided by each ventilator. It is used to see whether our ventilator is functioning properly or not. Now this is the simple breathing circuit. We can see this is the patient inlet. From here, the ventilator, first the inspiratory limb is connected to the ventilator through the patient inlet. We may have an optional bacterial filter, or we may not have an optional bacterial filter. It's our choice. Then this inspiratory limb goes to the humidifier, where the air is heated up to body temperature and humidified 100%. Then this heated and humidifier goes to the inspiratory limb to the Y-piece. There is water trap, which traps the water vapor, so that water vapor doesn't collect in the airway, which may cause airway resistance. And then from the inspiratory limb, the Y-piece is there. From the Y-piece, we can connect the nebulizer if we require, if there is some bronchospasm or in the case of pneumonia, like bronchial asthma, we can use a nebulizer or we can remove it. And this nebulizer is connected to the ventilatory ventilator. And then there is a flow sensor which has to be always connected, and then we can connect the HME filter if we are not using the humidifier of adequate size. Then this HME filter is connected to the NIV mask, like BiPAP mask, or we can connect directly to the ET tube to the patient. And from here, the patient exhaled here, goes from here through the bypass to the exhalation limb. Auto trap is also there in this limb, and then bacterial fill again to the ventilator. So these limbs, the inspiratory limb and the expiratory limb, both are connected to the ventilator, and this is the simple circuit. We have so many types of ventilator available, and this is very simple circuit which we have to connect to the ventilator. And I will be showing the videos also how to connect this limbs, the inspiratory limb and the expiratory limb, and how to start a ventilator. But if we are not able to set up this, since it's not one day, we will not be able to study all these things in one day. We can call the technician who is giving us the ventilator, and he will demonstrate the proper how to set up a ventilator, how to connect all these tubings. And this is very simple in new ventilators. These settings are very simple. This is the simple ventilatory display unit. We can see this is the on off button, this is the alarm, this is the rotatory knob. This rotatory knob is used to set various parameters. These blue squares are the parameters which we set on a ventilator. We can change these parameters by this rotatory knob. This is touch screen, and these are the black parameters. In the black squares, these parameters are the parameters which is derived by the ventilator. We don't set this ventilator, it's derived by the ventilator, but we have to keep monitoring, as this is a pressure control mode, CMB mode. In this is set, and we have to keep on monitoring the tidal volume in this patient so that it doesn't go beyond 6 to 8 liters per minute. And these are various graphs: the pressure time graph, the flow time graph, the volume time graph, pressure volume graph is also there. And we can have how the patient is getting we can have a graph, and some fluctuations can be seen, so that if these fluctuations are seen, we can go and observe whether there is any problem in the patient. So these are the references. If one have to have a more detail about the session, can go and see the references: Chang D, the clinical application of mechanical ventilation, IIP textbook of pediatrics, ICU protocol. The skills to be learned. It is important to understand and set all these parameters. The changes in parameters should be done according to the patient's clinical status and the ABG. ABG we have learned yesterday, and we always have to see the clinical status. When the patient is calm on the ventilator, means the patient is getting adequate ventilation, but the patient is fighting with the ventilator or is apprehensive, then we must go and see that whether what is the problem, where we are not adequate. So patient clinical status is very important to monitor, and we will be seeing the monitoring in the next session also. Further practical implication would be discussed in the mode section. The initial setting and the titration will be discussed further in the today only, in the coming lecture. My sincere thanks to all the contributor of this module. Thank you very much. Thank you all the panelists, the participants, and Chandrakanta ma'am, Shelly ma'am, TGME sir. Thank you very much. Now I'll be showing various videos. Mamta team, can you please display Mamta team? Yes, thank you.
और ये हमने इसमें सर्किट और टेस्लम तैयार करके रखा है। मैं आपको दिखा दूं, ये फ्रॉम द पेशेंट दैट इज एक्सपिरेशन, एंड ये टू द पेशेंट दैट इज इंस्पिरेशन। ये फ्लो मीटर के लगे हुए हैं। ये वेरी सिंपली इट अटैचेस हेयर है स्पायरोमेट्री के, ये यहाँ लगे हुए हैं स्पायरोमेट्री। ये लाइन यहाँ अटैच्ड है, यहाँ पे हमने फिल्टर अटैच कर रखा है, और ये टेस्लम अटैच है। अब मैं आपको बताऊंगा कैसे इस वेंटिलेटर को आपको ऑन करके चलाना है, यूज़ करना है एग्जैक्टली। इस वेंटिलेटर में आपके पास दिस इज द कंप्रेसर एंड दिस इज द यूपीएस। इन दोनों को बिजली की सप्लाई देनी है, करंट की सप्लाई देनी है, और ये है वेंटिलेटर। इन तीनों को करंट देना है हमको। वेंटिलेटर अपना करंट यूपीएस से उठाता है, तो वेंटिलेटर का जो सर्किट है वो यूपीएस पे लगा हुआ है। कंप्रेसर और यूपीएस, इनका कनेक्शन हमने यहाँ दे रखा है। ये यूपीएस के लिए है, ये कंप्रेसर के लिए है, और वेंटिलेटर की इलेक्ट्रिक करंट वो यूपीएस से आ रहा है यहाँ पे नीचे इस पॉइंट से। ठीक है, तो आपको दो आउटलेट लगाने हैं और वेंटिलेटर का इनलेट आपको यूपीएस से लेना है। अब इसको कैसे ऑन करना है? ऑन करने से पहले मैं इसे ऑफ कर देता हूँ। वेंटिलेटर बंद हो गया। ठीक है, आपने कनेक्शंस दे दिए, आपने बटन ऑन किए। आप आएंगे यहाँ पे, पहले बटन को ब्रीफली प्रेस करेंगे। पहले यहाँ से कंप्रेसर को ऑन करेंगे और यहाँ से फर्स्ट बटन को ब्रीफली प्रेस करेंगे फॉर 10 सेकेंड्स। यहाँ पे आ जाएगा वोल्टेज 230 वोल्ट्स का। वेंटिलेटर की मेन स्क्रीन पे आएंगे, यू विल कंप्रेस इट, सेल्फ टेस्ट एंड कैलिब्रेशन होगा। पास, नॉब को प्रेस करेंगे, स्टार्ट दबाएंगे, स्टैंड बाई मोड पे है। अपना मोड सेलेक्ट कर लेंगे, आप जो भी मोड यूज़ करना है आपको। सपोज आपको हमें प्रिंसिपल मोड यूज़ करना है, आपने मोड के लिए आपने स्टार्ट कर दिया और इंश्योर करना पड़ेगा, लिए कंफर्म कर देंगे, ये स्टार्ट हो।
So we can see the test link which is inflating, so the ventilator is functioning properly. This is the simple PM care ventilator which we'll be getting in our hospitals by government. Now we'll be seeing the next videos. This is a neonatal ventilator.
Hello everyone, today we will see about the mechanical ventilator, the parts of the ventilator, tubings, how to attach these tubing and how to start a ventilator, and the next part we'll see how to set the parameters for the pediatric patient. So this is the electronic ventilator which we are using in our ICUs. This is the main panel of the ventilator. Currently this is switched off. We have to switch on the ventilator from the back side. After connecting the charging port into the cable into the charging port, and also the humidifier, and we'll connect the cable of the humidifier to the port, and we'll start the ventilator. This will see the charging cable, lights of the charging cable are on. This is the button from which we'll start the ventilator. We'll press it for the long time and we'll see the main panel is getting displayed. It will take some time to for the main screen to come. Till the meantime we'll attach the tubings. So as all the ventilator we know, we have some basic tubings. We'll take the sterile tubing, either the fresh tubing which are coming in the market or the reusable tubing which have been ETO'd or sterilized. So after donning gloves and hand washing and donning gloves, we'll take out the tubing. This part which has a 3 plug, this is the expiratory tube. So these are the tubings. It has both inspiratory and expiratory part. So how to differentiate? The one with a thin, the white tubing generally with a thin inlet is the expiratory tube, and the blue one, other one is the inspiratory tube. So as we see, this is the attachment which goes on the patient end in the endotracheal tube, and this is the end which goes into the ventilator. So we'll start with the humidifier chamber. So this is the humidification chamber which will, as we can see, there is a line which gives us the level for the water, and only sterile water or distilled water is filled in the chamber. So this is our humidifier. We'll switch on the humidifier from this point. We'll push down the inlet and then gradually slide it down. So as a click sound has come, that means the chamber has properly fixed. Now we'll attach the tubings. So this port, this is expiratory port, and this is clearly mentioned is here is expiratory. So the expiratory port will goes into this. The second part, which is the short part of the inspiratory tube. So the one part goes into the inspiration as mentioned in here, like this, and the broad part goes into the humidifier chamber. So we'll put the humidifier chamber. This is the inspiratory port which is going from ventilator to humidifier. Second part will come from humidifier to the patient end. So this is the second part of the inspiratory limb. From humidifier, the broad end will goes into the humidifier chamber, and the second part into the patient limb. For timing, we'll attach the patient limb to the test lamp. There is one more tube which is oxygen tubing. This is attached from this proximal end of the ventilator up to the distal end of the expiratory limb. This is the point. Okay, so this is our tubing. Now comes the humidification. So for the how to attach the humidifier, since we have seen, we have switched on the humidifier, it is showing us the temperature. These are two modes, the invasive mode and non-invasive mode. Since we are doing the invasive ventilation, we'll select the invasive mode, and these two wires are there. So where to connect which wire? Since there are 3 ports, as you can see, we'll connect this proximal end into the inspiratory one, like this. The second part goes into the expiratory limb here, upside. Now the second tubing, the below one, as you can see, it has a blue point and has a cone-like thing here. So this cone get attached into the inspiratory limb. As you can see, there is a conical part for this blue thing. So we'll attach it here like this. Next comes its distal part. This is conical form, and this get attached into the inspiratory limb. So our inspiratory limb is humidified and heated. Now coming to the ventilator. So after attaching to the main source, we'll attach the air and oxygen. So from behind, please come behind. So and on the back side of the ventilator, as you can see, it's clearly mentioned the oxygen port and the air port. So when we'll trace down the air port, this white port is the oxygen port. So as we'll see, this white tubing will connect into the oxygen like this. We have to plug it down and then push. Similarly, air will plug it down and push. Second thing which we will see on the back side is the flow sensor. So from here, the flow sensor wire is connected, and it is then connected on the patient end like this. Now we'll start the ventilator. As we have switched on, this is the first screen which we see on the ventilator panel. We'll see the audio test. It is making sounds. Yes, we are able to hear the sound. Now here comes the second screen. Now we have to select which are we dealing with, the pediatric, like neonatal age group, or pediatric age group. So if we are here dealing with the neonatal age group, less than 10 kgs, well, and it's about the flow sensor. So how to calibrate the flow sensor? So we'll take the flow sensor, we'll block both of its end or with our palm, and then do the flow calibration. So as you can see, a green line has came and is saying it's calibrated. Will go on the main screen. I will connect it back. So this is the main panel. On main panel, you can see there are multiple things which is coming, and these are the modes. On baseline, you can see there CPAP, nasal CPAP, DOE CPAP, oxygen therapy. These are basically non-invasive modes, and the upside is control mandatory ventilation, assist ventilation, SIMV plus PSV and PSV. These are basically the invasive modes which we can give in the patients. Depending upon the modes, there are the control panel. There are the parameters which we can control, like the flow, trigger, I time, E time, the frequency, this FiO2, PIP and PSV, PEEP, oxygen, and volume limit. And this is the graph we can see depending upon what parameters we are seeing, whether the pressure, volume, or flow. So one by one, I'll tell you what settings which we are needed to set for different parameters.
So we have seen these videos, and there is some difference in various ventilators. So whenever we are not able to set up a ventilator, we have to call the technician. The supplier will come and tell how to set up or start the ventilator, and the various settings will be discussed in the how to set will be discussed later in the chapter. Thank you very much.
Thank you, Manisha, for this wonderful presentation. And I think you have already answered the query.
Yes, ma'am. EPAP and IPAP basically are pressures.
Yeah,
Yes,
yeah. As time is short, we are moving to the next session. The next talk will be taken by Dr. Payal. And Dr. Payal is from FHMC Firozabad. And she will be talking about the multi-para monitor. So welcome,
Very
Dr.
good
Payal.
afternoon, ma'am. Very good afternoon to everyone. Can I share my screen?
Yes, yes, sure.
My presentation will discuss multi-para monitor. Our learning objectives are different monitoring parameters, how to use the monitor, alarm settings, and how to maintain the device. Multi-para monitor itself, there is multiple parameter we can see in a single monitor. In general, basic models are used to monitor cardiac activity like ECG, heart rate, oxygen saturation, blood pressure, NIBP means non-invasive BP monitoring, and IBP, that is invasive BP monitoring, respiratory rate, and temperature. These monitor consist of sensors, communication links, processing device, and display. Additional specification according to model and makers. There are multiple brands available: Mindray, GE, Philips, Draeger, Silver, and Meditech, etc. There are different monitoring domains. These are in cardiology, we monitor ECG, cardiac output, continuous cardiac output monitoring, impedance cardiograph. In respiratory system, we see airway gases, lung mechanics, respiratory mechanics, neurology, EEG, and NMT. In mainly we are dealing with hemodynamic oxygenation and volumetry. In hemodynamics, we see invasive BP monitor and NIBP, SvCO2, SpO2, and perfusion index. In certain kind of monitors, we can also see tissue perfusion. This is RSO2. We can see the regional saturation of oxygen by certain type of probes and monitors. Temperature can be recorded by thermistors. These are the parameters we generally see. These are ECG, respiratory rate, SpO2, temperature, NIBP, IBP, central venous pressure, EtCO2, EEG, and regional oxygen saturation. These are additional settings we can see in certain kind of monitors. ECG can be read by 3-lead ECG, 5-lead ECG, 6-lead, or 12-lead. These are selectable settings. Generally in PICU and NICU, we generally use 3-lead ECG. This ECG gives us cardiac waveform and heart rate. By this, we can detect tachy and bradycardias and different kind of arrhythmias. ST segment and can be analyzed in QT analysis. We generally use 3-lead electrode placement. In this right, there are 3 sides you have to attach. Right arm placement directly below the clavicle and near the right shoulder. In left arm, this is again directly below the clavicle near the left shoulder. And lower limb placement is on left lower abdomen. This is the video.
part. One is the connecting cable, and second part that is connected to the cable and the ECG leads that have to directly attach to the baby. Usually we go for the 3-lead ECG with the left part, right part, and the lower limb component that has to be attached. We can also attach to the lower left abdomen of the baby. Leads has to be attached to the baby with the electronic pads. After connecting the lead to the baby and to the monitor, there is a direct display of the ECG on the display monitor, and we can directly assess the pattern of the ECG of the baby, involving the assessment of the any electrolyte imbalance or arrhythmia. ECG leads also give a heart rate of the baby, and in the setup we can select lower limit or upper limit of the heart rate according to the age of the baby and directly involvement and assessment of baby. Thank you.
Respiratory rate, it can be derived from CO2 monitoring or impedance through ECG leads. This is how the leads are attached. Impedance respiration is acquired using standard ECG electrodes and cables. Either lead 1 or lead 2 can be used for this. Pulse oximetry, these are the parameter we can see by pulse oximetry. These are different kind of probes. By pulse oximetry, we can see SpO2, perfusion index, PVI, and SIQ. SpO2 is a measure of oxygen saturation. In pediatric cases, saturation target is more than 92%, and in newborn, it is between 90 to 95%. It shows us numeric as well as graphical display. Probe placement should be in right upper hand in neonates. We have to avoid in limb in which BP is being measured, because it will show a fallacious reading whenever BP is, has been taken. Changing of probe site is important. Ear probes are also available. PI and PVI. PI is perfusion index. This is an indicator of peripheral blood flow. It compare the pulsatile to non-pulsatile signal. Its normal range is 0.02 to 20%. In some monitor, it is here, and in some monitor, it is here. If perfusion index is between 0.02 to 20%, we assume this reading is normal. PVI is plethysmographic variability index. It measures change in PI during respiratory cycle. Basically, it helps in assessing hemodynamic significance of PD and intravascular volume status in neonate. High PVI means there is indication of giving fluid boluses. PVI more than 14% shows response to fluid load. It can predict fluid responsiveness in infant undergoing congenital heart surgery. SIQ is signal IQ indicator. Quality of flow to area applied and hence signal quality. This is SIQ. Here it shows good SIQ and good plethysmogram. Here the SIQ is poor and poor plethysmogram, so the reading shown is not correct. Here the variable SIQ is good, but the pleth is variable due to motion artifact. Here the good SIQ with non-variable low pleth because of low volume. Temperature thermally recorded by the thermally sensitive resistors are used. Those are thermistors. The resistance change of thermistor is used to calculate the temperature. Up to 2 temperature sites can be monitored simultaneously, and the difference between 2 measured sites is calculated. Rectal temperature monitoring is also possible with special probes. NIBP is non-invasive BP monitoring. A non-invasive BP monitoring is using a oscillometric method. It based on the principle that pulsatile blood flow through an artery create an oscillation of arterial wall. Oscillometric method measures the mean pressure, and systolic and diastolic pressure is calculated by this. For NIBP, to determine the proper NIBP, determine the limb circumference. The width of the cuff should be 40% in neonate and 2/3 of the length of upper arm thigh in children. The inflatable portion should cover 60 to 80% of arm length. Application of cuff should be such that artery marking should be at appropriate place. It should be smooth and snugly fitting. We have to choose auto and deflate option. Average of 3 reading is ideal. Do not take in crying or agitated state because it will give a fallacious reading. These are the different kind of different sizes of BP cuff available. Now the video how to measure.
For the blood pressure monitoring of patient, we have this non-invasive blood pressure monitoring NIBP cable with the one end attached to the module, and the second end will attach to the disposable BP cuff. And BP cuff is available in the different size depending on the baby's age and the weight. After connecting the cable and the cuff to the baby, we will start measuring of blood pressure by pressing the knob or touching the screen. That option is available in the monitor. And frequency of measurement of blood pressure is can be manually, or it can be set in the according to the requirement, from varying from 5 minutes to every 2 hours. That automatically the monitor will assess the blood pressure. While the measurement of the blood pressure, the reading will be there, and ultimately at the end the blood pressure with systolic, diastolic and mean will appear on the monitor. In this baby, the blood pressure is the higher range, so alarm is blinking. For the alarm setter, we touch the parameter and the separate window will pop up, and according to the gestation of and age of the patient, we can decide the low and high for each systolic, diastolic and mean blood pressure.
Invasive blood pressure monitoring. It is used in critically ill patient. It shows us real-time recording. It shows both numerical and waveform. For invasive blood pressure monitoring, there are things needed. This is pressure bag. This is attached to this is pressure bag, and this is a IBP module. This pressure bag is attached to the IBP cable, and from here this is a IBP transducer. From here it is attached to the three-way. Here is radial artery is cannulated, which is attached to three-way. Three-way is attached directly to the IBP transducer. This transducer is attached to one portion is attached to the bag and other is attached to the pressure bag, IBP module. These are the things needed. This is the pressure bag, IV line, IBP transducer, IBP cable. These are the component of arterial waveform. The waveform consists of 4 components. Peak systolic pressure. This one is this peak is the peak systolic pressure. This is dicrotic notch. This is anacrotic notch, and this one is diastolic pressure. Aortic valve closure as a result of backflow from already existing pressure in aorta. This is the another waveform is shown here. This waveform, this reading is the diastolic BP, and this BP is the systolic BP. Here's the dicrotic notch. Now this explains here the aortic valves open. So hence this is the diastolic BP. As soon as aortic valve opens and blood flows in the aorta, pressure increases, it shows systolic BP. Here the aortic valve closes, this is dicrotic notch, and pressure start falling. EtCO2 is capnography, is the graphic display of CO2 concentration versus time, or expired volume capnogram during a respiratory cycle. Capnograph is the machine that generates a waveform, and the capnogram is the actual waveform. This is the there are 2 kind of capnographs. This is mainstream capnography and this is side stream capnography. In mainstream capnography, endotracheal tube is directly connected to the sensor. This sensor is connected to the display, and other end is connected to the circuit. In side stream capnography, endotracheal tube is connected to the sampling adapter. This sampling adapter is connected to the sampling tube and then is connected to the sensor and display, and this sampling adapter's other side is attached to the circuit. In measurement of EtCO2, we have to start with the expiration because CO2 increases in expiratory phase. As soon as the expiration begins, there is no CO2. As soon as it increase expiration is started, there is rapid rise of CO2 as air from alveoli containing CO2 reaches upper airway. In this phase, alveolar plateau CO2 reaches uniform level. The height of plateau is related to cardiac output. This end point of plateau is EtCO2 reading, and here the inspiration begin and CO2 start decreasing. These are the different capnograms. It shows normal capnogram and sudden loss of waveform. This may be because of ET tube disconnected, dislodged, kinked, or obstructed, or loss of circulatory function. Decreasing EtCO2 could be because of cuff leak, tube in hypopharynx, or partial obstruction. Capnography can also be used for assessment of CPR. We try to maintain at least 10 millimeter of mercury of pressure. And then if while doing CPR, there is sudden increase in EtCO2, it shows return of spontaneous circulation. During bronchospasm, there is shark fin appearance. It is due to asthma and COPD. When patient is hypoventilating, it broadens. In hyperventilation, it shrinks. Decreased EtCO2 may be because of apnea or sedation. Here is the video for EtCO2.
For the end tidal CO2 monitoring, we have a separate microstream sampling line that take the sample from the exhaled air and send it to the sensor that present in the separate module. In this Paediatric, we have a separate module that put into the satellite unit, and the sensor is present in this module. After inserting this module into the satellite unit, we have to plug in the microstream sampling line with one end to the module and other end connected to the baby, depending upon the baby on the invasive or non-invasive mode of ventilation. For the invasive mode of ventilation, we have a hub with connector to the ET and other end to the ventilator circuit. For the non-invasive mode of ventilation, we have a nasal cannula microstream sampling line that can be used for the baby. After connecting the sampling line, EtCO2 number will display on the monitor, and then we can regulate the baby's ventilation status by assessing the end tidal CO2 more frequently with the non-invasively, and ultimately that will increase the frequency of ABG and decrease the sampling of the baby.
Now the alarms, there are multiple alarms. These are audio-visual alarms. Heart rate depending upon the age, respiratory rate depending on age, BP you have to set up depending on the age, SpO2 90 to 95% for newborn and 92 more than 92% for children. Temperature have to be set between 36.6 to 37.6. ECG for arrhythmia. Maintenance of the device. Extension cable should be tucked up in a bag when not in use. Disposable accessories are as much as possible can be used. Reusable accessories to be cleaned with a sprit swab in between. Accessories when not in use should be kept in labeled boxes. So the key message is real-time monitoring of all parameters. Use the sensors properly. Set age-appropriate alarms. Early warning of adverse changes, or it gives us early warning of adverse changes or trends, response to therapeutic intervention, and it reflects proper functioning of other equipment too. These are the references. Skill to be learned over here is understand various parameters, identify compatible and appropriate sensors, identify and interpret abnormalities, and set alarm limits. Apart from these, most important monitor is clinician. Remain vigilant, integrate monitor information into patient care. My sincere thanks to all the contributors. Thank you. Thanks a lot. Any question?
Thank you, Dr. Payal, for this excellent presentation.
Thank you, ma'am.
I think there is no question related to your talk.
Okay.
So thank you very much. So we have learned about the basic terminology of invasive ventilation and how to do monitoring when the child is on ventilator. So we move to the next talk, that is the indications of mechanical ventilation and various modes of mechanical ventilation. And this talk will be taken by Dr. Anubha Srivastava. She is Associate Professor of Pediatrics at LMNMC, Prayagraj. So I welcome you, Dr. Anubha.
Good afternoon, ma'am. Thank you, ma'am. So I'll start sharing. So I welcome all the participants. So I'll be taking the talk on indication modes of ventilation. So basically, I'll be discussing the indications for ventilation. What are the causes of respiratory failure that will lead to a state when you will need to ventilate the child? Understand the different modes of ventilation and how to choose the appropriate mode according to the patient profile. So ventilation is basically, it is composed of two parts. One is oxygenation, where oxygen needs to enter the tissues via the lungs. And the second is the removal of carbon dioxide produced in the body. So it needs to be removed from via the lungs. So these are the two components of ventilation. And hence we have two kinds of respiratory failure. Type 1 is the failure of oxygenation. So basically this involves the surface, the alveolar capillary surface, where there is improper flow of oxygen from the air that we breathe into the tissue. And second is the failure of carbon dioxide elimination. This occurs when overall the pumping mechanism, the movement of air in and out of the lungs is impaired, so that we have a state where there is failure of carbon dioxide elimination. So what can be the causes of respiratory failure? So starting right from the central nervous system, so the respiratory center may be involved, it may be injured either due to various kind of poisoning or due to brain injury. So the respiratory drive may come down. The spinal cord either due to immune injury like trauma or myelitis. Peripheral nerves injury in cases of Guillain-Barré syndrome or neuropathies. Neuromuscular junction abnormalities as in myasthenia and toxins, respiratory muscles abnormalities as in myopathies. There may be obstruction in airway as encountered in asthma. So in all these, you can see there is a what we called a pump failure. There is a decrease in movement of air in and out of the lungs. So these all basically cause type 2 failure. However, alveolar damage as in pneumonia or in COVID ARDS or in cases of pulmonary hemorrhage, there is problem in diffusion of oxygen in the tissues into the through the air into the tissue. So this may cause type 1 of failure. So how do we diagnose respiratory failure? Because this is the first step. Once you diagnose respiratory failure, then only you can think of ventilating the child. So clinical parameters are quite sufficient in helping us diagnose respiratory failure. You may encounter tachypnea in the patient, or there may be dyspnea, which is then awareness of one's own use of accessory muscles, like there may be nasal flaring, the external nasal opening, you may see it flaring. There may retraction the sternal area. There may be chest drawing, either the whole of the chest may be collapsing, or there may be retraction in the intercostal muscles. Now, once this respiratory symptoms persist for, you may have secondary cardiovascular symptoms also, like tachycardia, bradycardia, sweating, people wounded in severe asthma. There may be hyper or hypotension. There may be diminished or absent breath sounds and presence of adventitious sounds like crepitations, spasms, so on and so forth. So once you have seen for these signs, you can go for investigations. You can monitor and find that there is low SpO2 in cases of hypoxia. If you do a blood gas analysis, that PaO2 levels are lower than 60 millimeter of mercury, or there may be increase in carbon dioxide in type 2 failure. When carbon dioxide, we are unable to expel out carbon dioxide, levels of carbon dioxide increase beyond 50 millimeter of mercury. And then we can get a chest X-ray and CT scan done, although not required always to diagnose respiratory failure. These may be done to get hold of the cause, the basic pathology leading to respiratory failure. Overall, there may be subjective assessment. There may be increase in work of breathing, which is wholly subjective, felt by the patient. So how do we treat respiratory failure? So there are various stages of respiratory failure. Into various stages, we may have different interventions. If there is only hypoxia, only the oxygen reaching the tissue levels, then oxygen therapy is sufficient. But if there is hypoxia along with hypercarbia, that is the oxygen levels have come down and also there is carbon dioxide accumulation. But if the patient has a good spontaneous effort, we can go for non-invasive ventilation. The most severe scenario is severe hypoxia and accumulation of carbon dioxide, but the patient have poor respiratory effort. This we can encounter in the sickest of the babies. So there, invasive ventilation is our only choice of modality. So what are the goals of mechanical ventilation? As there are two causes of respiratory failure, decrease in oxygen and accumulation of carbon dioxide. So goals of mechanical ventilation is also bi-pronged. One is increase in level of oxygen and decreasing the carbon dioxide level. So basically, as we have discussed in the morning sessions, oxygenation is determined by the mean alveolar pressure and FiO2. So you can alter these two parameters to improve oxygenation, and to improve ventilation, you can manipulate the respiratory rate and the tidal volume, which overall determine the minute ventilation and bring about proper ventilation. So these are the various modes of ventilation. We'll be each one of these separately with their advantages and disadvantages. So before that, a short words on anatomy of the ventilator. So as you can see here, ventilator usually has two inputs, oxygen and which goes through a blender, which determines the amount of oxygen or the percentage of oxygen that is to be delivered. This is through the inspiratory limb, where we have the inspiratory valve, which allows unidirectional flow of the air. Then we have a flow transducer, which gives a feedback to this inspiratory valve, and then inspiratory limb leads to the lung. So here there is the exchange of gases, and then these gases go to the expiratory limb. Again, we can here have flow and pressure transducers, which determine the regulation of this expiratory valve, the expiratory limb. And it is this regulation of this expiratory valve that determines the PEEP that is delivered to the lung. So if you make this outlet, increase the outlet, so this pressure is transmitted back to the lung, and then you can have a small amount of PEEP delivered to the lung, so that even during expiration, the alveoli remain open and have small amount of pressure there. So coming to the first mode of ventilation, the controlled mandatory ventilation. So here you can see, here as the name suggests, the ventilation is totally controlled by the ventilator. The patient does not have any input for this kind of ventilation. So here the ventilator delivers a pressure at a constant flow. Then there is an inspiratory pause, and then the patient has expiration. So here none of these triggers or the control is by the patient. It is fully controlled by the ventilator. So all parameters here are controlled by the ventilator, and the patient cannot even trigger the ventilation. So it can be used only in apneic patient who is not breathing at all. And if the patient has even small amount of spontaneous breathing, then there will be asynchrony, because the ventilator will be delivering its breath at the predetermined rate, pressure, flow. And if the patient has his own breaths in between, then those may not be aligned with these ventilator delivered breaths, and there may be asynchrony. So if the patient is having even slightest of spontaneous breathing, you need to have heavy sedation and muscle paralysis so that the ventilator can totally take over the ventilation of the patient. Second is the assisted controlled ventilation. Here again, it is completely controlled by the ventilator. The only difference is the small negative deflection that you can see here at the beginning of this curve. This deflection is due to patient's effort, and this acts as a trigger for the ventilator. So once patient triggers the initiation of ventilation, the ventilator completely takes over, and then according to the predetermined set parameters of pressure, flow rates, and the time duration, the ventilator delivers the predetermined amount of pressure or volume. So only difference with the CMV or control ventilation is that here the trigger is by the patient. Rest again here also the ventilator completely takes over. So once triggered, most of the parameters are controlled by the ventilator only. Disadvantage is that there is possibility of hyperventilation as each effort is assisted. So if the patient is having small triggers, then the ventilator will support each of the triggers as full breath, and then we may have a situation where the patient may have been hyperventilated. And again, if the patient has these small triggers or initiation of breath, then these can lead to asynchrony between various phases of respiratory cycles, because here you can see if the patient has triggered the inspiration, and then he has enough energy to complete the whole cycle of ventilation, then his expiration will be asynchronous with the inspiratory phase of the ventilator. So there are chances of asynchrony in this mode of ventilation. The third one is the synchronized intermittent mandatory ventilation. This is the most common form of ventilation, and I think most of us are used to working with only. So here you can see the trigger is again initiated by the patient, and in synchronized intermittent mandatory ventilation, you set the number of breaths that are to be supported by the machine. So suppose you have set the setting at 20. So out of the total breaths of the patient, only 20 breaths will be supported by the machine, and rest, suppose he's breathing, the patient is breathing at the rate of 40 and you have the rate at 20. So 20 breaths will be supported by the machine, and rest 20, the patient will have its own spontaneous breathing. So what quotes is given, you can see. So while talking about the ventilatory supported breath, so in that the patient starts breathing, here is the trigger by the patient, and then the machine takes over. It's at a constant flow, it gives the pressure that to which the set, and then it completes the cycle. So now it has some time duration before the next breath, which is to be supported by ventilator, will come. So in between, the patient can have its own spontaneous breath. So here it is a smaller graph. Because we are dealing with a sick child, we are not expecting him to put a effort as high as that of ventilatory supported breath. So in between the ventilated supported breaths, the child may have spontaneous breathing. So the patient is free to breathe during expiratory pause between two mechanical breaths. So what is the advantage? Here the patient can breathe spontaneously between mechanical breaths. So he is comfortable because only breaths are routed by the machine, as I gave example, and rest 20 he is free to breathe at his own pace. So ventilatory support can be tailored according to the patient's demand. So if the patient is improving and is able to take more breaths at a greater effort, so we can decrease the number of ventilated supports. So gradually the patient can be weaned off. So this is a mode which can be used for weaning also by gradually reduction of the mandatory breaths. Here we can reduce the need for sedation because we need the patient to have spontaneous breathing. So for that there needs to be the level of sedation needs to be low, so the child can have the need for sedation is reduced, and preservation of respiratory muscle atrophy, because whenever he is having spontaneous respiration he is using his own muscles, so his muscles don't go into atrophy. However, the disadvantage is that if the child is very sick, he may not be able to sustain small amount of spontaneous breathing that he is supposed to take, and so he may face increased work of breathing during spontaneous breath, and gradually he may be more ventilator dependent or may require increasing of ventilator setting, and there may be some amount of expiratory synchrony. This suppose if we have said that is to be supported by at a high rate, so the child may not have sufficient time to have spontaneous respiration in between the ventilator supported breaths. So there he may have asynchrony because he may want to have an expiration, but the ventilator, because it has to deliver the breath, so it may start an inspiration. So there you may get a asynchrony. Next is the pressure support ventilation. Here the inspiratory pressure support is applied to spontaneous breath. So what happens in this pressure support ventilation? Is my audio not clear? I am getting few messages. Okay, I'll continue.
So it's clear now.
Okay,
You can
ma'am.
continue. So in between, there was voice was a little bit cracking.
Okay. So in pressure support ventilation, the inspiratory phase is supported. So it was originally developed to relieve the work of breathing in the spontaneous breaths that the child used to have in between the in SIMV mode. So those breaths that the child used to take spontaneously, they were given an inspiratory support so that it can achieve the levels of pressure that was required for good ventilation and oxygenation. But now it can be used as an independent mode itself of and is used as weaning method also. So here again the initiates a breath, and then an inspiratory flow is delivered, and the pressure that we have set, that the pressure that needs to be attained, suppose you have set it at 8 mm of Hg, the patient is not able to having a spontaneous breathing but is not able to attain a pressure of suppose 8 mm of Hg. So he is able to generate only say 4 or 5 mm of Hg. Then the ventilator will support and give the rest of the pressure, so that the ultimate in each inspiratory cycle the pressure of 8 mm of Hg is attained. So it supports in building up the pressure required in the inspiratory phase. So the inspiratory flow is continued to maintain the target pressure support as long as the patient's spontaneous effort continues. So here basically what we are doing is you can see that it is the breath is triggered by the patient. Here each breath is triggered by patient, as you can see each breath is triggered by the patient, but the pressure is quickly built up by the ventilator and brought to the level that we have set, that is required for good oxygen and carbon dioxide levels. So there the ventilator brings that pressure level to the set level, and then the child can have expiration. So only the inspiratory phase is supported and the pressure that is required is achieved. So all the breaths here are initiated by the patient, and once initiated, the ventilator supports the inspiration. pressure support only as supports the breath of the patient only as long as the patient is in inspiratory phase. There is no support in the expiratory phase. Only in the inspiratory phase, the pressure is brought down. The expiration is again passive. So what parameters do we need to set? So we have to set the trigger at which the ventilator will take over. So it can be a flow trigger or it can be pressure trigger. We need to set the pressure support level to what we need the ventilator to support the patient's efforts. We need to set the support slope, whether it will be a gentle slope or a spiky slope, very rapid increase, that again needs to be set. And we set the expiratory trigger. And as in other ventilatory settings, we need to set the PEEP, FiO2 and other alarms as in other modes. So the advantage is it preserves the patient's spontaneous effort because it's triggered by the patient. So he is free to have spontaneous effort. Patient has control on all the phases of respiratory cycle because only his inspiration is supported. Expiration is at his own free will and triggers when the frequencies again as patient's will. It relieves the work of breathing in proportion to the level of pressure support because the patient doesn't have to spend his own energy to bring about that high pressure levels. That ventilator helps it to take the pressure levels to a higher value. So the patient's work of breathing is relieved. However, its disadvantage is that it can be used only in spontaneously breathing patients because in very sick apneic patients, if they are not able to have even trigger the breaths, so the ventilator cannot be of any help. However, another disadvantage is there is variable tidal volume and minute ventilation varying with lung mechanics. We will be discussing about this in further slides. So volume controlled ventilation and pressure controlled ventilation, this has always been a question, which one should we opt for? So the best key point to make your decision is that you should opt for, both are good. You should opt for the method in which you are comfortable, and you should look for the best synchronization and the method which is able to give you the best parameters. So that is the mode that you should opt for. So in pressure controlled ventilation, the ventilator delivers an inspiration at a pressure level pre-fixed time. So here you can see the pressure is quickly brought to the level that we have set, and how long this pressure will be continued, again that is prefixed. So the ventilator gives a set pressure for a fixed duration of time. However, tidal volume is variable and determined by the lung mechanics. So I'll be explaining this a little. So you see, you have suppose you have set a pressure of say 10 millimeter of mercury for a patient. So the ventilator knows that he has to, all throughout the phase, in the respiratory phase, has to maintain this pressure of 10 millimeter of mercury. So now if the lung is very expandable, is compliant, so with this pressure the amount of air entering the lungs will be more. However, on the other, because the ventilator only sets the pressure, so amount of volume delivered will be determined by the elasticity of the lung tissue. So if it is more elastic, so at the same pressure, more air will be able to enter. On the other hand, if the lungs are stiff due to pneumonia or ARDS, then the volume delivered will be very low because these high pressures, this pressure suppose of 10 mm of Hg will be attained very quickly because the lungs are itself stiff. So volume of air will be delivered. So the tidal volume is delivered with each breath is variable and depends upon the elasticity of the lung tissue. So in pressure controlled ventilation, their advantage is that there is limitation on airway pressure because we have already set the maximum pressure that attained. So there are less chances of a barotrauma. However, because of set pressure, we know what pressures we are giving, and that is maintained continuously. So alveolar, more and more alveolar are recruited. They are opened. And there will be alveolar requirement. Disadvantage is that there may be variable tidal volume. So again, as I have explained, the volume delivered will be variable, and with high mean airway pressure, because there will be decreased compromised on the venous return, so there may be hemodynamic dysfunction. So in volume controlled ventilation, ventilator delivers pressure to achieve set tidal volume. So you can see the blue graph here. So here the volume, the controlled tidal volume remains unchanged. Irrespective of the lung compliance, the volume that is delivered is always constant. However, the result of it is that the pressure that is delivered is variable with each breath, and the slope also varies. So the flow remains constant because the ventilator calculates the volume that it has to deliver, the pressure it knows that the lung tissue is offering, so it calculates and ensures that the flow remain constant. The volume delivered is already set, and it ensures that the volume is same is each breath. So the result is that the pressure varies with each breath. So as it is a supported ventilation, it reduces work of breathing. It allows patient to increase minute ventilation. So and we cannot, because we set the minute ventilation, the amount of ventilation that is to be delivered, the tidal volume that is to be delivered. So it ensures that the minimum volume is always delivered. You cannot decrease below it. So the minimum minute ventilation is ensured. The disadvantage is that there is potential adverse hemodynamic effects, again due to decrease in venous return due to hyperventilated lungs. So there may be potential hemodynamic results. The airway pressure vary with changes in lung compliances. So again, because we are delivering a fixed volume, so again on the elasticity of the lung tissue, the pressure may, and there may be high flow demands from the patient that cannot be met because we have already set the total volume that is to be delivered. So if we compare the volume controlled ventilation and the pressure controlled ventilation, you can see here that in volume control, the flow is constant, and in pressure control, the pressure is constant. So in volume control, hence, if we see, the pressure is variable, and in pressure control, the flow is variable. The alveolar pressure is in pressure cycle, you can see since the airway pressure is more or less equal, so alveolar pressure is also reached quickly, and it is more or less at a constant level, which is not so in case of volume cycle ventilation. So to end my talk, the key message is to look for synchronization, and patient triggered ventilation are preferred because then you can have a better synchronization. The patient is at more comfort. However, in many sick children, you may need to give assist control ventilation, because there the ventilator need to completely take over the patient's ventilation to bring about the parameters in the normal range. In mild to moderate illness, SIMV mode can be preferred. The best mode is the one in which we are confident in handling, and we should monitor the deliver parameters. Suppose you are giving a fixed pressure, so you should have an eye on the volume that is being delivered, because then volume is not is a thing that is depending upon the lung compliance. So you should have an eye on the volume so that it doesn't exceed the safe limits. And similarly, if you are setting a fixed volume, then you should have an eye on the pressure that is achieved. And again, you should set an alarm so that you can have you can maintain the parameters in the desired levels. So these are the references. I thank all the contributors. Thank you.
Thank you, Dr. Anubha, for this lucid and excellent and informative presentation. So there is one question for you. In which case we use PSV mode?
Pressure support. Pressure support is the foremost requirement is that the child should be having spontaneous respiration. So because in that pressure support, each and every breath is triggered by the patient. So only in spontaneously breathing patient, if you are seeing that the child is breathing spontaneously, but is not able to maintain the parameters in the normal range, so that means he is able to build up the pressure, but not to the level that is required for normal oxygenation or ventilation. So there you can have pressure support to give him that extra support that is required to bring about the parameters to the normal range. So there you can use. Another use is in case of weaning. So in the next lecture, in the following lecture, you will see where you will be taught about weaning. So there it can be used as a weaning method, so that you can gradually decrease the support and the patients take over his ventilation. So these are the two modes where you can use pressure support ventilation. But the basic bottom line is that the patient should have uh, his spontaneous respiration.
Okay, thank you, Dr. Anubha. And now it's time for a lunch break. So we are taking a short break for 20 minutes, and after 20 minutes session will be resumed. So stay with us. We have 3 more important topics left, that how to intubate a child who needs mechanical ventilation, how to initiate ventilation, what should be the parameters, what should be the settings, and how to change them according to the need of the patient, and finally how to wean off the child from ventilator. So this all will be discussed after lunch. So we'll meet again after 20 minutes.
Thank you, ma'am.
I hope all the participants are back. So we start our session again. So before starting ventilation, we have to intubate the child. So Dr. Kavita Meena from IMS BHU is going to tell us that how to intubate a child and how to manage airway of a child. So Dr. Kavita, are you here? Please. So we are starting soon. Just wait for 1 minute. Okay, so Dr. Kavita is here. So I invite you, Dr. Kavita, to start your talk. So you have to unmute yourself.
Now I am audible, ma'am?
Yes, yes, you are audible.
Okay, ma'am. Okay, ma'am. Now, in this afternoon session, we'll be discussing about endotracheal intubation in children. Our learning objectives will be understanding the key anatomical differences between pediatric and adult airways, and comprehension of equipments and preparation required for endotracheal intubation in children, procedural steps of performing endotracheal intubation. So we'll be discussing indications, contraindications, anatomy, preparation, steps, aftercare, potential complication, and common pitfalls. Indications: if there is failure of oxygenation or failure of ventilation, if the partial pressure of oxygen is less than 60 millimeters of mercury on 60% FiO2, or if the arterial partial pressure of carbon dioxide is more than 50 millimeters of mercury, or if there is any inability to maintain or protect the airway, severe systemic conditions like hypotensive shock, or patients require cardiopulmonary resuscitation, or patient require anesthesia, or any procedures requiring sedation, or patient is suffering from any neuromuscular disorder. There are no absolute contraindications for endotracheal intubations, but there can be certain relative contraindications, like if there is anticipated difficult airway, patient is difficult to intubate, or patient requires alternative airway other than endotracheal intubation, or we are waiting for an expert team, then these are the certain contraindications. There is a difference in the anatomy of the adult airway and the pediatric airway. So in case of adult airway, the airway is cylindrical in shape. In case of pediatrics patient, it is funnel shape. Tongue is relatively small when it is compared to the pediatric patient. And epiglottis is shorter, whereas in case of pediatric patient, epiglottis is floppier and epiglottis is U-shaped. So this makes epiglottis easily collapsible, which can lead to obstruction. And again, tongue, since it is comparatively large, so if there is a patient under sedation or patient GCS is not full and patient is not able to protect his or her airway, then this tongue can lead to obstruction. If we talk about the narrowest part, then in case of adult patient, vocal cord is the narrowest part. In case of pediatric patient, it is the cricoid ring, which is the narrowest part. If we see the overall position of the airway, then in case of adult, airway is not much anteriorly placed as compared to the pediatric airway. Pediatric airway is anteriorly placed, so it makes our job bit difficult. So, for proper endotracheal intervention and for proper laryngoscopy, what we need is the airway alignment. As we can see in this slide, a child when lying on the horizontal surface, we can see there is a relatively larger head size in infant. So this because of this large head size, there is a neck flexion, and this neck flexion compresses the soft tissues. Tongue is relatively large, so tongue keeps falling back, which leads to the airway obstruction. So what we need to do is do the airway alignment and achieve the sniffing position. So this is the sniffing position. And in this position, if we see the endpoints, then the glabella should correspond to the chin. They should come into the straight line. Neck, there should not be flexion. Neck should be wide and open. And if we see the external auditory meatus and the suprasternal notch, again, they should correspond to each other and they should come into a straight line. So how we can achieve this? We can put headrest, check the endpoints, and again, if these are not achieved, then place the shoulder roll and again check the endpoints. So that's how we achieve the sniffing position. This is again the slide which is showing difference between the sniffing position and the position which is not right, and what we need to do to correct this position and achieve the sniffing position. So again, this is a slide which is showing sniffing position, or we can also call it as ear to sternal notch position. So in this, there is a line which is passing from the ear of the patient and anterior part of the shoulder. And this line should be parallel this line should be parallel to the horizontal surface. So how to achieve this? In case of infant, by placing a shoulder roll, we can achieve this position. In case of small child, we may not need anything to place. And in case of older child or in case of adult, if we put a headrest, then this positions can be achieved. So after obtaining optimal position, we need to know what are the structures that we need to identify. So these are the structures which lines the glottic opening of the patient. So this is vallicula, this is epiglottis. These are the epiglottic folds on both sides. And this is the glottis, and these are the vocal cord. Vocal cords are the two glistening white structures which lines the glottic opening. So these are the anatomical landmarks that we need to know. Again, this is the slide which is showing the anatomical landmarks. And in this slide, one important thing which is shown is the esophagus. So this is where we make most of the mistakes. So we should have a clear-cut picture in our mind, how the glottic opening look like and how the esophagus look like. When we see the glottic opening, again, we are seeing these two glistening white structures which lines the glottic opening. So we should aim for this. So there are different shapes of epiglottis. Shape changes according to the age. So in case of newborn, it is inverted U shape. In case of child, it is triangular. In case of adult, it is semicircular. So this is how the shape changes. So for attempting the procedures, we need to do certain preparation. And we can remember this preparation by mnemonic SOAP me. So we need suction apparatus. Suction apparatus can be wall mounted or it can be standalone. Pressure should be around 80 to 100 millimeters of mercury. Suction tube should be available, and suction catheters of size 8 to 14 should be available. Then we need to give oxygen to the patient, which can be given by non-rebreather mask or by nasal cannula. or ambu bag with reservoir bag, or we might need oxygen tubing depending upon the patient's condition. For the airway, we need appropriate size of endotracheal tube. Then we need oral airways and nasopharyngeal airways. And we might need laryngeal mask airway. It should also be available in case we face any difficulty. Then personal protection equipment, which are also must. Then other things when we need is the medications. Medications can be divided into pre-medications, paralytics, and the resuscitative medications like epinephrine, atropine, fluids. And in the equipments, we need laryngoscope, appropriate size blade for the laryngoscope, appropriate size mask, ambu bags, stillets, working IV lines, syringes, tapes, towel, pads for airway alignment, stethoscope, monitor, and tidal carbon dioxide or the calorimetric capnograph. And after doing laryngoscopy and intubation, keep the ventilator ready. So these are the different type of laryngoscopes that we use in case of pediatric patients. This is the Miller blade and the other one is the Macintosh blade. Miller blade is straighter, thinner. It can be used in infant and children. And when we are using the Miller blade, so there is a direct lifting of epiglottis which is involved. And Miller blade provides better control of tongue. Whereas in case of Macintosh blade, it is more curved and it is wider. It is used in older children and adults, and it is the tip of the blade is placed into the vallecula, and then the lifting of epiglottis is done. So this blade curves around the tongue and keeps the tongue away from the view. So these are the different sizes of laryngoscope. For preterm, we need Miller blade 000 For term, we need Miller blade 0 to 1. For infant and toddler, Miller blade size 1 is required. For from preschool children to school children, we can use Macintosh blade, which is size 2 and 2 to 3. How do we calculate the appropriate size of endotracheal tube? So if we are using uncuffed tube, use the formula age in years by 4 plus 4. If we are using cuffed tube, then use the formula age in years by 4 plus 3. And a size above and a size below should also be kept ready, apart from the size that you have calculated. For the depth of insertion, again, we can remember it by the formula age in years by 2 plus 12. Or we can roughly multiply the internal diameter, which is given on the package of the endotracheal tube, by 3. And cuff pressure, we should always keep under 20 centimeters of water so that not to hurt the mucosa of the pediatric patients. So these are the different sizes of endotracheal tube. Size of the tube is labeled according to the inner diameter of the tube. And for the inner diameter, there is a corresponding external diameter. And this external diameter depends whether your tube is cuffed or whether your tube is uncuffed. So these are the corresponding external diameters which are given for the corresponding internal diameters. The other equipments that we require is the stillet for endotracheal tube, which can be these kinds of stillet, or we have elastic bougie. So these aids into the intubation, and sometimes they help in preforming the shape of the endotracheal tube. So that's how these equipments are helpful. Then we need an ambu bag. The sizes of the ambu bag is different. For the neonate, it's 200 to 300 ml. For infant and young children, we can use 450 to 500 ml. For adolescent and older children, we use 1000 to 1500 ml. Then we need appropriate size mask, and how we can calculate the appropriate size mask. Keep the mask slightly on the face of the patient, on the nose and the mouth, and the triangular area of the mouth, triangular area of the mask should be on the bridge of the nose, and we should see the mask should not be small enough as not covering the nose and mouth, and it should not be large enough that this is covering the eye of the patient. So that's how we can calculate the mask size. Then holding the mask, it is again very important to know how do we hold the mask. So there is a C and E technique. With the C technique, we press the mask slightly on the nose and mouth of the patient, and with the E technique, we place our fingers on the bony prominence of the chin, and we try to lift the airway by giving slight upward and outward movement to the mandible. So this is called jaw thrust. Jaw thrust helps in opening the airway and aligning the airway. So we should master the technique of giving jaw thrust. Then there is two hand technique. In this two hand technique, again we use our fingers to pull the mandible outward and upward, and with the thumbs we press the mask on the nose and mouth of the patient. Then we need suction apparatus. So for corresponding endotracheal tube size, catheter size is there, and these catheters are also color coded, and these catheter goes according to the size of the endotracheal tube. Keep the pressure 80 to 120 millimeters of mercury. If we talk about the oropharyngeal airway, again the size of the oropharyngeal airway can be calculated by keeping the oropharyngeal airway at the midpoint of the incisors, and the distal part of the airway corresponds to the angle of the mandible. Curvature should be in the upward direction. So that's how we can calculate the appropriate size of the Goodell's airway, which is oropharyngeal airway. The sizes which are available are 00 to 4, and it is usually 4 to 20 centimeter in length. And it is very best in our interest that we remember this, that this is how the size is calculated. Otherwise, color coding is also available, so we can remember it by the colors as well. The other adjoint equipments that we require is the dynaplast or the micropore for securing the endotracheal tube, and monitor, which requires pulse oximetry and capnography, and personal protective equipments, which are very important. For the pre-medications, we need tranquilizers like benzodiazepines and promethazine, opioids, fentanyl, morphine, non-opioid analgesics like acetaminophen, dissociative agents like ketamine, anticholinergic agents, glycopyrrolate or atropine, antacids, and H2 blockers like ranitidine and metoclopramide. We can use midazolam, we can use ketamine. These can be given by intravenous route or the intramuscular route. So the doses are different and the time of onset is also different. Then we need drugs for resuscitation just in case we face any complications. So we should have a epinephrine loaded syringe, which should be in the dilution of 1:10,000, and the dose is 0.01 mg per kg IV. Then we might need atropine if we face bradycardia in the dose of 0.02 mg per kg. We need to give fluid resuscitation to the patient. So IV fluids like normal saline should be ready, or we might need calcium gluconate and hydrocortisone. So these are the drugs which should be kept ready. We usually do rapid sequence intubation in COVID patients or in trauma patients, in full stomach patients. So apart from the 7 P's that we have already discussed, the other important thing for rapid sequence intubation is use of neuromuscular agent. So whenever we are using neuromuscular agent, first of all, check ventilate the patient, because if we are doing procedure in a very hasty manner and we have not done check ventilation, then we might land up into not ventilating and not able to intubate. So we don't want to face the situation. So whenever we are using neuromuscular agent, always check ventilate the patient, at least in case of anticipated difficulty airway, or I would say in all the patients, because you might not know what can be the situations once we have given the drugs to the patient. So always do check ventilation. Drugs for rapid sequence intubation can be different induction agents like etomidate, propofol, ketamine, fentanyl, midazolam. These drugs have its own advantages and disadvantages. So before using the drug, we should know the potential complications, and we should remember how we can resuscitate the patient just in case we land up into these complications. For the depolarizing paralytic agents, we can use succinylcholine in the dose of 1.5 mg per kg, or the non-depolarizing agents that can be used are the rocuronium and vecuronium. So we need to do pre-oxygenation. So use 100% oxygen for 3 to 5 minutes. Why? Because it extends the safe apnea time. And if the patient is spontaneously breathing, then use the non-rebreather mask or the nasal cannula. Or if the patient is in apnea or patient is in gasping situation, patient is not breathing spontaneously, then give bag and mask ventilation. So step one is proper position, which is the sniffing position. Lay the patient on the horizontal surface, give a slight neck extension, uh, then achieve this proper position. Then hold the laryngoscope. Try to hold the laryngoscope into the non-dominant hand so that the dominant hand is free for opening the airway or other airway manipulations. For the holding of laryngoscope, there are two techniques which has been described. So if we are using the classic technique, we are holding the laryngoscope by the handle with the full grip. Or if we are using the other technique in which we are holding the laryngoscope near the blade. So in case of pediatric patients, some gentle manipulations are required. So this technique is helpful. If you have not mastered this, then you can use any technique you are convenient with. So this is how we hold the laryngoscope. Then opening of the mouth, we use scissoring technique to open the mouth. Push the lower lip by the thumb and upper part of the mouth by the fingers. Then gently insert the laryngoscope. Always use the angle of the mouth to insert the laryngoscope. Never go through the middle. Always use the angle. So this is the technique in which we are introducing the blade of the laryngoscope from the angle of the mouth of the patient, and we introduce through the angle of the mouth, and then we keep deviating the trunk towards the opposite side. So this is how we introduce the laryngoscope. And this is the full blade which is inside the mouth of the patient. Then this is the technique which is shown, which is wrong. And in case of landmarks, we have already discussed. Once you are inside the mouth of the patient, these are the landmarks we need to view in order to do the endotracheal intubation. And keep on advancing the blade and do this movement in a very gentle manner, because sometimes if we are being very harsh, then we might lead to trauma to the patient. So we don't want to do that. So this is how you are inserting the laryngoscope. And as for the cricoid pressure, we can use cricoid pressure in certain situations, but cricoid pressure usually distort the anatomy of the patient. So if we are not very convenient with the technique, we should basically avoid this, because it makes our identification of anatomical landmarks bit difficult. So engage the blade into the vallecula and then do the lift. So once we have lifted the epiglottis, this is the glottic opening that we will see. And then we insert the endotracheal tube after identifying the glottic opening. And our aim is putting the endotracheal tube through this glottic opening. So after intubating the patient, we need to check for the correct placement. And this correct placement can be checked by bilateral chest rise with each ventilation, or if there is any on auscultation, there should be equal air entry bilaterally. And if you auscultate the abdominal area, breath sound should not be audible on the abdomen. Oxygenation should be adequate. SpO2 should be more than 90%. And if we are using the capnography, then capnograph shows a waveform, which is very typical of endotracheal intubation waveform. Chest X-ray, if we are using, then the tip of the tube should be 3 centimeter above the carina. So this is the capnographic waveform, which we see on the monitor once we have achieved a successful endotracheal intubation. Then we can use LMA insertion. In certain situations, we are not able to intubate the patient, but we need to protect the airway. We need to intubate. Then we can use LMA. So if we are using a laryngeal mask airway, first of all, deflate the cuff of the laryngeal mask airway, then lubricate this dorsal surface of the laryngeal mask airway. Always hold the laryngeal mask airway into the pen holding fashion. Then slide the laryngeal mask airway along the hard palate and roof of the mouth. Once we have inserted the laryngeal mask airway, inflate the cuff of the laryngeal mask airway. There will be slightly outward movement of the laryngeal mask airway. And for checking, again, we should attach the circuit or the ambu bag, and we should check for the ventilation after insertion. Once we have achieved our airway intervention, be it endotracheal tube or be it by the laryngeal mask airway, we need to secure our equipment, and for that we use Dynaplast. Dynaplast is very sturdy, which provide better sticking of equipments. So this is how we secure the endotracheal tube. We take a part of Dynaplast, we slit in between, and then we paste it around the endotracheal tube. So this is how you secure the endotracheal tube. This is again showing securing the endotracheal tube. There are different techniques to secure the endotracheal tube. Sometime where you paste the tape, it also depends which part is require manipulation, and these are the various techniques. Then there can be potential complications that we face, which can be hypoxemia, which can be bradycardia, or which can be hypotension, hypertension, laryngospasm, bronchospasm. There can be trauma to the mouth, larynx or vocal cord, or we can do esophageal intubation, missing the vocal cords, and we might lead to perforation, or there can be tracheal perforation, or patient may land up into emesis, which can lead to aspiration or cardiac arrest. There can be acute deterioration post-intubation. So we need to rule out conditions like displacement or misplacement of the endotracheal tube, or there can be obstruction of endotracheal tube, or there can be pneumothorax, or there can be equipment failure or ventilator failure. So the unsuccessful attempt are because of certain common pitfalls that we do while doing the procedure, like rocking movement of the laryngoscope. So we should avoid this. Or sometimes we are not able to visualize the glottic opening because blade is inserted too deep. This is very common in case of pediatric patients. We miss glottic opening in case of pediatric patient if we have inserted the blade too deep, or improper positioning. You have not achieved the proper airway alignment, so you will face difficulty in laryngoscopy and intubation. Or we have done the right mainstream endotracheal insertion, only one side of the lung is being ventilated, or because we have taken the multiple attempts. So we should always try to keep our attempts within less than 3 in 20 to 30 seconds. Or we should always have a checklist before attempting for procedure, any procedure, be it laryngoscopy or intubation, or be it any other procedure. We should always have equipment checklist. So in case of COVID-19, first of all, the important thing is the adequate personal protection. So that should be available. Experienced person should perform the procedure. We should always avoid awake intubation, and inflate the cuff of endotracheal tube once it is inserted and before starting the bag and mask ventilation, and always use inline suction catheters rather than the open catheters. And there are innovations which really help us in identifying the airway and laryngoscopy and intubation, and we also protection from the infection like viral filters. Or we can use video laryngoscope. Video laryngoscope provides certain distance from the mouth of the patient and provides the proper visualization. So airway structures can be identified on this screen. So this is how it helps in endotracheal intubation. So our take-home message is pediatric intubation is an important skill in the management of critically ill children. So relevant anatomy is very important. We should have a knowledge of that. Appropriate equipment should be kept ready at all times in the pediatric ICU crash cart. Medications are an important component during intubation, so we should have an idea of the dose of the complications. Stepwise insertion should be performed for optimal success. Post-intubation care is an essential part of intubation process, and complications should be anticipated early and treated early. Thank you. These are my references.
Thank you, Dr. Kavita, for explaining everything so beautifully. So let me see any question for you. So I think there is no question related to your talk. So thank you.
Okay, ma'am. Thank you, ma'am.
Okay, so now we know how to intubate a child. We know the basic concepts of ventilation, various terminology. Moving to our next talk, that is how to ventilate and how to change the settings of ventilator according to the need of the patient. And this talk will be taken by Dr. Yashwant Kumar Rao. Dr. Yashwant Kumar Rao is HOD of Pediatrics at GSVM Kanpur. And he is joining us soon. He is facing some technical issue. So just wait for a few seconds and he is joining us soon. There is some network issue, Dr. Yashwant. He is joining us soon. So wait for a few minutes. Okay, so Dr. Yashwant has joined now.
Yes. Hello.
Okay, welcome Dr. Yashwant.
Namaskar, ma'am.
Namaskar.
Hello.
Please, so please
Am I
start.
audible?
Yeah, you are audible. Please start.
Hello.
Yeah, you are audible.
Hello. Am I audible, ma'am?
Yes, you are audible.
Hello.
You are audible, Dr. Yashwant.
Hello. Hello. Am I audible?
Sir, you are audible.
Hello.
Yes, Dr. Yashwant, we can hear you.
चलो अरिच बोल रहा हूँ। ये क्या है जरा बताना, ये स्पीकर हाई डेफिनेशन डिवाइस है ना, यही है ना? माइक्रोफोन तो है नहीं, ये हटा दे।
अनम्यूट का ऑप्शन अभी आया था ना सर, आप उस पे क्लिक करें।
नहीं जा रही है, इसका स्पीकर कैसे आएगा? हेलो हेलो
Yes, Dr. Yashwant, you are audible.
Hello.
Please start.
ऑडिबल सर लिखा तो है, ऑडिबल सर। हेलो चंद्रकांतम, आई कैन नॉट हियर यू।
But we can hear you.
यू आर ऑडिबल, ठीक है।
सर ये विंडो बंद कर
हेलो जी, हाँ अच्छा। अरे अरे जरा वॉल्यूम जरा इसका बढ़ाना। वॉल्यूम कहाँ से बढ़ेगा इसका? मैं बढ़ा रहा हूँ, एक मिनट। अच्छा, इसी पे हर बार करता हूँ। अभी आवाज आ रही है इस समय?
Yes,
अच्छा
yes.
वो हमारा माइक सिस्टम बहुत ही पुअर था, इसमें बहुत नीचे था। अब आ गई? हाँ हाँ, हम बोलते हैं, ठीक है, ठीक ठीक ठीक, थैंक यू। तो शुड आई स्टार्ट?
Yes,
Okay,
Dr.
thank you.
Yashwant.
या थैंक यू मैम। वो वॉल्यूम हमारा बंद हो गया था, आई एम सॉरी।
No issues.
टेक्नोलॉजी में पुअर हूँ हल्का फुल्का। So
We all are learning.
now we are going to start invasive mechanical ventilation and initial settings and how to titrate. So our patient has been intubated by our intensivist, and we have to put the patient on ventilator, invasive ventilator, and how to ventilate, how to set the initial setting, and how to titrate according to the vital and other parameter of the patients. We will start with the case. Our case is 10-year-old male patient, OB child, fever for 5 days, myalgia for 5 days. So during COVID time, any fever, any myalgia, any URI is taken as COVID, and in this child, RT-PCR was positive 5 days ago. Like in first wave, second wave, everybody has become the doctor. We were the just observer. Everybody start oxygen and remdesivir, everything at home. When they deteriorates, means ki on cylinder, when they are not getting enough oxygen, they used to come to the hospital. Same way this patient admitted to the hospital 3 days ago. Started progressive worsening, and oxygen requirement has increased by NIV support, and patient was put on non-invasive ventilation with FiO2 of 80%, quite high FiO2, and support was 12/8. In BiPAP, we start with the 12/8. PEEP should be 7 to 8. PIP should be 12/30. So we have started a good setting. Then let's see what happened. On examination, child was sick. We have started BiPAP. Child was sick. So what was the findings in the examination? Child was sleepy. Why child was sleepy? Was there any CNS problem? No, child was having pneumonia. So sleepy means कि child was having CO2 retention. Child appears tired, थका हुआ. Whenever there is CO2 narcosis, go and read today. Child become depressed, sweating over the forehead, sleepy, and seems lethargic. Heart rate was 135. It was tachycardia. It should be around 100. Respiratory rate was 50 per minute in spite support 12/8, non-invasive ventilatory support, and 80% FiO2. Still respiratory rate was 50. Quite tachypneic, quite tachycardia and CO2 retention. Chest movement appears shallow. क्योंकि अब ये फाइटिंग छोड़ रहा है बच्चा, इसलिए स्वेलो होती जा रही है. पहले बहुत तेज से सांस ले रहा था, डीप ब्रीथिंग ले रहा था, अब ये स्वेलो होता जा रहा है, मींस की CO2 नार्कोसिस डेवलप होती जा रही है. Bilateral cracks were there in both the lung fields. Oxygen requirement 80%, support 12/8. Pulse oximetry shows oxygen saturation of 89 to 90%. You know, on room air SpO2, जहाँ पे 21% ऑक्सीजन है, SpO2 should be 95, 96, 97, 98. But in this patient, 80% means कि अगर आप देखें तो 4 गुना ज्यादा ऑक्सीजन देने के बाद भी saturation was 89 and 90, and support 12/8 means कि lungs have become very bad. And saturation, one more thing, saturation falls rapidly to 80% when he removed the mask to drink water. Friend, this part is very important because in second COVID wave, we have seen the adult patient, whenever if they take out the mask and saturation dip little bit, means ki from 90 to 90, 84, 85, 86, it was okay. But when it reduces to 70, 80 very rapidly, we were not able to save those patients, or if they saved, but they saved with a very difficulty on intubation and many more things. So this shows कि child's lungs are very bad. He has not able to eat anything since one day. What to do next? So this child definitely, very important part is clinical parameter, and clinical parameter is saying that this child needs ventilatory support. Otherwise, with respiratory rate of 50, child will develop fatigue and arrest. And after this phenomena, you cannot save the child even you put on the ventilator. Putting the child on ventilator is an art, because putting the child on ventilator aim is to take out as much early as possible. So we will discuss the ventilatory mode, respiratory rate, how to set the tidal volume, inspiratory or expiratory ratio, FiO2 and PEEP. So which mode is the best? So already sir has been, you people have been taught by the sir about the mode. I just mentioned two things. One is CMB mode, that is controlled mandatory ventilation. Second is ACMB, and third is SIMB. कंट्रोल्ड मैंडेटरी वेंटिलेशन क्या होता है कि हर, मान लीजिए हमने सेट किया फ्रीक्वेंसी 50, तो 1 मिनट में 15 फ्रीक्वेंसी, मतलब हर 4 सेकंड पे एक ब्रेथ होगा. तो हमने हर 4 सेकंड पे एक ब्रेथ आ रहा है, हर 4 सेकंड पे एक ब्रेथ आ रहा है. इस बीच में या उस ब्रेथ के साथ में पेशेंट अपनी सांस ले रहा है या नहीं ले रहा है, वेंटिलेटर को कोई मतलब नहीं है. Many times what happen when the ventilator patient is started exhalation, मतलब वो expire कर रहा है, ventilator ने inspiration दे दिया, what happen? Airway pressure will be quite high, pneumothorax and barotrauma will be there. So this is the bad things about the CMB mode, and nowadays we are not using CMB mode in any patient. Second is ACMB mode. ACMB mode is like SIMB mode. दोनों में क्या difference है? In ACMB mode, each and every breath will be supported. Each and every breath. मतलब 15 आपने सेट किया फ्रीक्वेंसी, तो 15 ब्रेथ सपोर्ट करेगा ही करेगा. इसके अलावा अगर पेशेंट अपनी 10 और ले रहा है तो उन 10 को और सपोर्ट करेगा. तो इससे प्रॉब्लम क्या होगी? There will be problem of hyperventilation. With each supported breath, volume will be increased because of support. So each breath will be supported. So CO2 wash out will be there, which will be again a problematic. Friends, at our place, we are using only and only SIMB mode. And what is the beauty of SIMB mode? SIMB mode is, suppose we set 15 frequency, so only 15 breath will be supported, either initiated by patient or given by the ventilator. And other breaths besides 15 will not be supported. Second thing I want to tell here, nowadays ventilators are coming SIMB mode with pressure support. Pressure support. तो हमने मान लीजिए 12 का प्रेशर सपोर्ट लगा दिया और पेशेंट अपने आप 6 जनरेट कर रहा है, तो 12 6 18 का सपोर्ट हो गया. तो इन SIMB mode with pressure support or volume support, we can have this type of beauty in our newer type of the ventilator. More than 15-16 modes are there, but try to use the mode to which you are familiar. Don't try to learn or don't try to use the modes to which you are not familiar. तो हमने चूज कर लिया कि हम SIMB मोड पे रखेंगे, या आपको लगता है आप SIMB पे ACMB पे बेटर करते हैं तो आप ACMB पे करिए. सेकंड पार्ट इज प्रेशर लिमिटेड और वॉल्यूम लिमिटेड. इन प्रेशर लिमिटेड, सपोज हमने एक प्रेशर सेट किया. प्रेशर इज बेसिकली PIP, दैट इज पॉजिटिव इंस्पिरेटरी पीक इंस्पिरेटरी प्रेशर. तो हमने मान लीजिए 18 का प्रेशर रखा. ये हमेशा हम 12 से ऊपर रखते हैं, क्योंकि नॉर्मली हमारे प्लूरा में -6 का प्रेशर चाहिए इंस्पिरेशन के लिए, वेंटिलेटरी ट्यूबिंग के लिए 6 चाहिए. तो 6 6 12 का प्रेशर तो हमें चाहिए ही चाहिए. तो हम 12 13 14 15 16 17 18 डिपेंडिंग अपॉन द कंडीशन ऑफ लंग. अगर बच्चे को केवल ब्रेन की प्रॉब्लम है तो हम 13 14 रखते हैं अगर लंग सही है. लेकिन हमारे इस बच्चे में लंग बड़ा पुअर है तो हम 19 20 21 पे सेट करेंगे. तो प्रेशर लिमिटेड मींस कि व्हेनेवर द प्रेशर इन द लंग्स और सर्किट रीचेस दैट प्रेशर, मतलब हमने सेट किया 20, तो 20 के बाद से वेंटिलेटर कट ऑफ कर देगा वॉल्यूम देना. तो प्रेशर लिमिटेड. सेकंड इज वॉल्यूम लिमिटेड. फ्रेंड्स, वॉल्यूम जो हम देते हैं वो 6 to 8 ml पर केजी से देते हैं. ये 30 किलो का बच्चा है तो 3 छक्के 18 180 ml हमने वॉल्यूम सेट कर दिया. जब भी वेंटिलेटर 180 ml वॉल्यूम दे देगा, that ventilator will stop working. Now he is not going to give more volume. तो प्रेशर लिमिटेड एंड वॉल्यूम लिमिटेड. इंपॉर्टेंट पार्ट क्या है, इन प्रेशर लिमिटेड सपोज हमने 20 प्रेशर सेट किया एंड 20 प्रेशर पे हम क्यों प्रेशर सेट किए हैं, ताकि एक डिजायर्ड वॉल्यूम 6 ml पर केजी लंग्स को डिलीवर हो. लेकिन लंग्स इतने खराब हैं कि वो 6 ml केजी के बजाय केवल 3-4 ml पर केजी दे रहे हैं. तो बेसिकली इंपॉर्टेंट पार्ट टू टेल टू ऑल ऑफ यू इज कि इन प्रेशर लिमिटेड मोड always monitor volume, how much volume is being delivered to the patient's lung, and in volume mode monitor the peak pressure. Suppose 180 ml volume deliver, lungs are very bad, 180 ml volume deliver करने के लिए peak pressure 40 जा रहा है, क्या होगा, न्यूमोथोरैक्स हो जाएगा, lungs हमारे और ज्यादा ट्रॉमेटिक हो जाएंगे. तो बेसिक पार्ट यह है कि वॉल्यूम मोड में मॉनिटर द पीक प्रेशर, जो कि आपके स्क्रीन पे आएगा. प्रेशर मोड में आप वॉल्यूम को मॉनिटर करिए. तो वी हैव कवर्ड वेंटिलेटरी मोड. नाउ कमिंग टू द रेस्पिरेटरी रेट. तो रेस्पिरेटरी रेट बेसिकली यू डोंट हैव टू रट इट आउट कि इतना 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 नहीं. ये हमारा डिस्क्रिप्शन, हम कितना रखना चाहते हैं, लेकिन हमें फिजियोलॉजिकल रेंज में रहना चाहिए। जैसे इफ इट नियोनेट, तो नियोनेट में नॉर्मल रेस्पिरेटरी रेट 40 से 60 होता है, तो हम 40-45 पे सेट कर सकते हैं। 1 महीने से लेके 1 साल के बीच में या 2 महीने से लेके 1 साल के बीच में रेस्पिरेटरी रेट हम 50 से नीचे रखते हैं। तो हम कितना होता है, नॉर्मली 20-30 के आसपास होता है, तो हम 25-30 के आसपास रख लेंगे। 1 साल से 5 साल में 20-25 के आसपास रख लेंगे। ऐसे ही, तो ये एक आर्बिट्ररी है, आपने जो भी आपने सेट किया, बट यू हैव टू टाइट्रेट कि हमने क्यों इतना सेट किया। हम इसका बेसिकली उसका क्लिनिकल स्टेटस देखेंगे कि पेशेंट इज इंप्रूविंग और नॉट इंप्रूविंग। अगर हमने एबीजी कराया, CO2 रिटेंशन हो रहा है, तो हम रेट को बढ़ा देंगे। तो इंपॉर्टेंट पार्ट है, जितना छोटा बच्चा होगा उसका रेट उतना ही ज्यादा सेट करेंगे। एडोलेसेंट या एडल्ट में उसका रेट 12 से 15 के बीच में या कम रेस्पिरेटरी रेट में सेट करते हैं। तो वी हैव चूजन SIMB मोड, SIMB मोड इधर वॉल्यूम कंट्रोल और प्रेशर कंट्रोल। सेकंड इज रेट हमने सेट कर दिया। अब ये हमारा बच्चा है जो 10 साल का है, तो हम कितना रेट रखेंगे, हम 18-20 रखेंगे। थर्ड इज टाइडल वॉल्यूम और इंस्पिरेटरी प्रेशर, थोड़ा बहुत वी हैव डिस्कस्ड, बट हियर मेन प्रॉब्लम इज हाइपोक्सीमिया की जब भी मास हटा रहा है तो बिलो 80 हो जा रहा है। तो वॉल्यूम शुड बी 6 ml पर kg, दैट इज 180 ml वॉल्यूम हमने सेट कर लिया। इंस्पिरेटरी प्रेशर दैट इज PIP 20 से 22 सेंटीमीटर ऑफ वाटर पे सेट करते हैं। इंपॉर्टेंट पार्ट है, हम चाहे दोनों में किसी पे रखें, चाहे वॉल्यूम पे रखें चाहे प्रेशर पे रखें, इंपॉर्टेंट पार्ट इज व्हाट वी वांट टू अचीव। वेरी वेरी इंपॉर्टेंट इज एडिक्वेट चेस्ट राइज। समटाइम जब सेडेशन इज लेस, चाइल्ड गर्दन घुमाता है एंड ही मे एक्सट्यूबेटेड हिमसेल्फ, उस समय बड़ी प्रॉब्लम आती है। तो चेस्ट राइज विल नॉट बी देयर, तो ऑलवेज मॉनिटर चेस्ट राइज एंड if volume limited mode is used, monitor the pressure in the circuit, जो कि already we have covered. It should not go beyond 32 centimeter of water, otherwise there will be trauma in the lung. And if we are using pressure limited, means कि 20 से 22, तो volume should be around 180 ml। सपोज वॉल्यूम आपने स्क्रीन पे देखा, ये आते हैं मेजर्ड पैरामीटर, आप उसमें डालेंगे तो स्क्रीन 1, स्क्रीन 2, स्क्रीन 3 करके आता है। हर वेंटिलेटर की अलग अलग सेटिंग होती है। जो भी आपके यहाँ इंस्टॉल करने आ रहा है उससे आप पूछिए कि भैया जो हम सेट करेंगे वो कहाँ पे आएगा, और जो ये शो करेगा, मॉनिटर करेगा सेंसर, वो कहाँ पे आएगा। और बहुत बड़ी प्रॉब्लम आती है, अगर सेंसर हमारे गड़बड़ है तो क्या होता है, ऑक्सीजन सेल गड़बड़ है, सेंसर हमारे गड़बड़ है, तो ये सब पैरामीटर एडिक्वेट नहीं आते हैं, तो आप मॉनिटर नहीं कर पाते हैं। तो अगर नहीं है तो फिर हम क्लिनिकली मॉनिटर कर लेते हैं, चेस्ट राइज देख के मॉनिटर कर लेते हैं। तो इन प्रेशर लिमिटेड वॉल्यूम शुड बी 180 ml। तो हमने मोड में SIMB मोड कर लिया, रेस्पिरेटरी रेट सेट कर लिया, या अगर हमने प्रेशर मोड पे रखा तो हमने 20 का प्रेशर रखा, या वॉल्यूम मोड पे रखा तो 180 ml वॉल्यूम पे हमने सेट कर दिया। नाउ कमिंग टू IE रेशियो। IE रेशियो हमने रेट सेट कर दिया। अब मान लीजिए ये बच्चा जो है एक नियोनेट है जिसका हमने रेस्पिरेटरी रेट 40 रखा। तो फ्रेंड्स, रेस्पिरेटरी रेट 40 का मतलब 1 मिनट में 40 बार सांस लेना, मतलब एक सांस के लिए 1.5 सेकेंड का टाइम मिला। हमने I रखा तो IE रेशियो शुड बी 1:2 to 3। तो इस बच्चे में अगर हमने 0.5 सेकेंड का I रखा तो 1 सेकेंड का हमारा E हो जाएगा, तो 1:2 का रेशियो हो गया। हमने अगर 0.3 का I रखा तो 1.2 का हमारा E हो जाएगा, एक्सपिरेटरी टाइम हो जाएगा, तो 1:4 हो जाएगा। तो हम 0.35, 0.4 रखते हैं तो अपने आप हमारा E सेट हो जाता है। तो वी हैव टू सेट द I, E अपने आप सेट हो जाएगा। तो नियोनेट में I जो होता है काफी कम होता है। अब आ जाइए बड़े बच्चों में, मान लीजिए 12 साल का, 13 साल का या एडल्ट है, उनकी नॉर्मल रेस्पिरेटरी रेट 15 के आसपास होती है। 12, 13 साइकिल हुई, 15 चौके 60, 4 सेकेंड की एक साइकिल में 1:3 लाने के लिए इसका इंस्पिरेशन 1 सेकेंड का, तो एक्सपिरेशन विल बी ऑफ 3 सेकेंड। तो 1:3 के रेशियो में आई हमारा 1 सेकंड का हो गया, लेकिन नियोनेट में हमारा आई हो गया 0.4-0.5 सेकंड का टू अचीव 1:2-3. इंपॉर्टेंट पार्ट ये है कि आई ई रेशियो शुड बी 1:2-3. तो हमने SIMB मोड रखा, हमने रेट अपना सेट कर लिया, वॉल्यूम और PIP सेट कर लिया, IE रेशियो सेट कर लिया. नेक्स्ट पैरामीटर इज FiO2. FiO2 is the parameter which should not be taught to all of you because you all are aware. Important part is FiO2 should be according to the patient status. जैसे हमारे पेशेंट में थोड़ा सा भी मास्क हटाते ही सैचुरेशन इज कमिंग बिलो 80, तो हम हायर ऑक्सीजन पे रखेंगे से 80%, 90% एंड ग्रेजुअली हम SpO2 को मॉनिटर करते हुए टेपर करेंगे. अगर कोई पेशेंट है जिसका 92 मिल रहा है लेकिन टैकेपिया बहुत ज्यादा है, आपको लग रहा है फैटिक में जा रहा है, हमने उसको इंट्यूबेट किया, तो हम उसका FiO2 50% से स्टार्ट कर सकते हैं. तो इट डिपेंड्स ऑन द क्लिनिकल कंडीशन ऑफ द पेशेंट एज वेल एज SpO2 monitoring by the pulse oximeter and tolerability of the patient. हम इस हिसाब से अपना FiO2 सेट करते हैं. Important part is always try to keep the SpO2 between 92 to 95. It should not come below 92 and it should not go beyond 95. If it is going, then okay, but you don't have to increase the FiO2. Always try to keep the FiO2 below 60. Ideally 30, 25 is the better. तो वी हैव कवर्ड SIMB मोड, रेट हमने सेट कर लिया, हमने प्रेशर मोड पे सेट कर लिया, आई रेशियो सेट कर लिया, FiO2 सेट कर लिया. नाउ लास्ट पैरामीटर इज P. इन कोविड निमोनिया ARDS is the main feature. Here we should start with at least 7 to 8 centimeter of water. 7 to 8 centimeter of water and child is hypoxemic. What the PEEP is doing? PEEP क्या करता है? What is PEEP? जैसे अगर हम एक गुब्बारे को फुलाएं तो इनिशियली हमें हाई प्रेशर लगाना पड़ता है एंड इसके बाद गुब्बारा फूल जाता है. हमने इसको छोड़ा, गुब्बारा फुस से निकल जाती है एंड गुब्बारे के अंदर वॉल्यूम 0 हो जाता है. कोविड लंग इज लाइक दैट गुब्बारा. जो पेशेंट एक्सपायर करता है, lungs have tendency to collapse, for which what the child is doing, they used to expire with partially closed glottis like what is why they are doing that because they try to generate own PEEP inside the lung so that they can prevent collapsing of the alveoli. So friends, here in COVID pneumonia surfactant loss is there, they have been effaced, so lungs have tendency to collapse. So what we do, we have to apply the PEEP. This is the fundamental phenomena of HFNC. This is the phenomena of bubble CPAP. This is the phenomena of BiPAP. All are what they are doing. They are putting a positive pressure inside the lung, inside the airway to prevent their collapse. And what it does, ये क्या करता है, हमारे पूरे एयरवे को डिस्टेंडेड रखता है. जो एल्वेलाई कोलैप्स्ड है उसको ओपन अप कर देता है, जो ओपन अप है उसको कोलैप्स होने से रोकता है. तो इससे वॉल्यूम सरफेस ऑफ एक्सचेंज ऑफ ऑक्सीजन एंड कार्बन डाइऑक्साइड इंक्रीज कर जाता है. तो PEEP इज वेरी इंपॉर्टेंट पार्ट इन कोविड निमोनिया और एनी टाइप ऑफ निमोनिया. It helps recruitment of the alveoli, so oxygen requirement will be reduced. It helps the lungs to take the better part of the compliance. अभी आगे एक डायग्राम में I will explain. It prevent atelectotrauma. All the time, if we are not applying PEEP, alveoli are getting collapsed, then they are being opened up, then collapse, then open up. This is known as atelectotrauma. What the adverse effect of the high PEEP? In pediatric patient, in adult patient, intensity at my place intensivist were say 14-15 तक जाते थे, but in pediatric patient try not to go beyond 12. Excess PEEP causes compression inside the lungs, inside the over the right atrium. So return from the superior vena cava and inferior vena cava will be decreased. Stroke volume will be decreased, cardiac output will be decreased, so BP will fall, hypotension will be the problem. So to prevent it, don't go beyond 12. Of course, barotrauma. What are the other setting? Trigger sensitivity. So friends, in the ventilator, we have trigger sensitivity. Two types of trigger are there. One is flow trigger and second is pressure trigger. What is flow trigger? जैसे पेशेंट को इंट्यूबेटेड है, पेशेंट ने सांस लिया, तो there is negative pressure inside the circuit, negative flow. That negative flow will be sensed by the ventilator and the ventilator will support that breath. That is flow trigger. One is second is pressure trigger. So on the ventilator side, trigger is there, sensor is there. Whenever the patient inspire, there will be negative pressure inside the circuit that will be sensed by the trigger. Nowadays, most of the ventilators are having flow trigger, and flow trigger should be set between 2 to 4. 2 to 4. हम इसको बढ़ाते तब हैं अगर पेशेंट इज वेरी टैकेपनिक, सिडेशन कम है, एंड इवन विद सिडेशन पेशेंट इज वेरी मच टैकेपनिक, तो हम थोड़ा सा ट्रिगर बढ़ा देते हैं सो दैट कि कम ब्रेथ को वेंटिलेटर सेंस करेगा और सपोर्ट नहीं करेगा. इससे क्या होगा कि हाइपर वेंटिलेशन की प्रॉब्लम थोड़ी कम हो जाएगी. बट ट्राई नॉट टू डिस्टर्ब द ट्रिगर बिकॉज दिस इज द ट्रिकी पॉइंट. यू हैव टू set the trigger according to ABG and patient's clinical parameter. So 2 to 4 is okay. Put the 2 and be happy with SIMB and volume or pressure support. FiO2, play with these button, not with the trigger button. Rise time. The inspiration suppose is 1 minute. So 5 to 10% is the set. Few ventilators don't have rise time, but अगर हमें ज्यादा वॉल्यूम ऑफ वेंटिलेशन चाहिए तो हम राइज टाइम को कम कर देते हैं, अगर कम चाहिए तो हम राइज टाइम को बढ़ा सकते हैं. बट डोंट टच द राइज टाइम. इट शुड बी सेट बिटवीन 5 to 10%. तो आवर सेटिंग्स आर, हमने अपने बच्चे को प्रेशर कंट्रोल पे रखा, SIMB प्रेशर कंट्रोल बोर्ड पे रखा. इसीलिए PIP हमने 22 का सेट किया क्योंकि पेशेंट्स का लंग बहुत ही ज्यादा खराब था. पीप हमने 8 पे रखा. रेस्पिरेटरी रेट हमने 18, 15 से 20 के बीच में कितना भी रख ले, 18 रख दिया. आई रेशियो 1:2, FiO2 80. ट्रिगर अभी हमने 0 रखा है, हम चाहते हैं उसकी सारी ब्रेथ को सपोर्ट करना. सिडेशन स्टार्टेड, बेडाजोलाम एंड फेंटानिल. अब हम मॉनिटर क्या करेंगे, व्हाट टू बी मॉनिटर. हमने वेंटिलेशन क्यों किया था, क्योंकि चाइल्ड वाज स्लीपी, चाइल्ड वाज लेथार्जिक, चाइल्ड वाज हैविंग टैकेप्रिया, चाइल्ड वाज हैविंग टैकीकार्डिया. चाइल्ड को हमने सिडेशन दे दिया तो बीपी फॉल करेगा. तो क्लिनिकल पैरामीटर में हमें यही मॉनिटर करना है. एक तो हमें चेस्ट वाइज मॉनिटर करना है, बहुत इंपॉर्टेंट पार्ट है. दूसरा पार्ट है कि उसका रेस्पिरेटरी रेट थोड़ा कम हुआ कि नहीं हुआ, 50 से 40, 30 हुआ कि नहीं हुआ. टैकीकार्डिया जो 135 था वो कम हुआ कि नहीं हुआ. चेस्ट राइज ज्यादा फॉल कर गया तो हम ये पेशेंट जो बिल्कुल स्लीपी था वो एक्टिव हो गया, आंख खोल के देखने लगा, हाथ पैर हिलाने लगा कि नहीं हिलाने लगा. दिस इज द थिंग्स, क्लिनिकल थिंग्स व्हिच वी हैव टू सी. सेकंड इज, अगर हमारे पास EtCO2 है तो हम EtCO2 देख सकते हैं. हमारे पास पल्स ऑक्सीमीटर है तो हम SpO2 देख लेंगे. वेंटिलेटरी पैरामीटर में हमने चूंकि प्रेशर मोड पे रखा है तो हम टाइटल वॉल्यूम देखेंगे कि 180 ml के आसपास डिलीवर हो रहा है कि नहीं हो रहा है. एयरवे का मीन एयरवे प्रेशर, पीक एयरवे प्रेशर हम देख लेंगे, वो सारे वेंटिलेटर में आजकल सेट आता है. मिनट वॉल्यूम हम देख लेंगे. ये सब कैलकुलेट करके कैलकुलेटेड स्क्रीन में सब शो करता है. यू हैव टू जस्ट सी कि या इट्स नॉर्मल और नॉट. ABG, डोंट रश फॉर द ABG. ABG कराओ, ABG कराओ, ABG कराओ. I have seen during second COVID, many more people are saying ABG कहाँ है, और वो ABG में देखते क्या थे, PO2 कितना है, PCO2 कितना है, बस ठीक है रखो. नहीं, whenever we are suspecting there is a mixed disorder, means the renal system is also involved, some sort of acidosis also involved because of high sugar decay is also there, lactic acidosis is there, then we need ABG. Otherwise you don't do frequent ABG. How to optimize the ventilation? अगर vital sign improve नहीं कर रहे हैं तो what could be the causes? हमने अपने यहाँ जो सबसे important cause पाया है कि patient क्या करता है, Goodell's airway हम लोग यूज कम करते हैं तो हम syringe को काट के मुंह में लगा देते हैं. तो what the patient is doing, because of high load नहीं कर पाते हैं पूरा, तो बिकॉज ऑफ हाई लोड पेशेंट क्या करता है, हल्का सा लेस सिडेटेड है तो इंडोट्रैकियल ट्यूब को च्यू कर लेता है, दबा लेता है, तो वॉल्यूम डिलीवरी नहीं होगा, पीक का प्रेशर हाई होगा, वेंटिलेटर में अलार्म आएगा और आपका वार्ड बॉय या स्वीपर जाके अलार्म को बंद कर रहा है। दिस इज द रॉन्ग थिंग। तो इफ वाइटल्स आर नॉट इंप्रूविंग मीन्स की ईदर यू हैव टू अपग्रेड द सेटिंग। अगर पेशेंट अंडर सिडेटेड है, फाइट कर रहा है, तो उसको फुली सिडेट करना है, फीवर है कंट्रोल करना है, कोई सिक्रीशन है, इंडोट्रैकियल ट्यूब में ब्लॉकेज है या क्लिंचिंग कर रखा है, इन सबको सही करना है। चेस्ट राइज अगर इनएडिक्वेट है तो हम पीआईपी को बढ़ाएंगे। कहीं ऐसा तो नहीं, कई बार झाड़ू पोछा लगाते समय ट्यूब पे पोछा पड़ा, ट्यूब डिस्लॉज हो गया, चेस्ट राइज होगा ही नहीं। तो यू हैव टू सी ऑल द टाइम इफ देयर इज एनी प्रॉब्लम, यू हैव टू चेक द वेंटिलेटर काम कर रहा है कि नहीं कर रहा है, सारी सर्किट सही है कि नहीं सही है, इंडोट्रैकियल ट्यूब सही है कि नहीं सही है, और जहां तक जा रही है ट्यूब वहां तक का पूरा एरिया पेटेंट है, सिक्रेशन है तो डू द सक्शन, और अगर एक्सेसिव चेस्ट राइज है तो हम पीआईपी को कम करेंगे। हम लोग बात कर रहे थे अभी कि हम बाद में डिस्कस करेंगे कि एरिया ऑफ गुड वेंटिलेशन लंग्स का कौन होता है। तो यू कैन गो A, B, C, D, ये चार हमारे स्क्वायर हैं, यू कैन सी इन द ग्राफ, और ये लूप है। ऑन एक्स एक्सिस देयर इज द प्रेशर, प्रेशर चेंज करने पे कितना वॉल्यूम इंक्रीज हो रहा है ये शो कर रहा है। तो यू कैन सी फ्रॉम हियर टू हियर हमने प्रेशर बढ़ाया, मतलब अगर हम इसको सेंटीमीटर में देखें तो 4 सेंटीमीटर का प्रेशर बढ़ाया तो लगभग 0.5 सेंटीमीटर का वॉल्यूम बढ़ा। वॉल्यूम इज नॉट इन सेंटीमीटर, इज क्यूब। हम एक एज्यूम करते हैं कि केवल इतना बढ़ा, 4 बढ़ाने पे केवल 0.5 का बढ़ा। अब देखिए यहां से एंड ऑफ ए से लेके इनिशिएशन ऑफ सी तक का देखिए, इन दोनों के बीच में भी लगभग 4 का वॉल्यूम बढ़ा, लेकिन 4 का प्रेशर बढ़ा, लेकिन वॉल्यूम बढ़ा हमारा लगभग 5 के बराबर का। दिस इज द कंप्लायंट पार्ट ऑफ द लंग, दिस इज द कंप्लायंट पार्ट ऑफ द लंग। अगर हमारा पी यहाँ पे रहेगा, व्हाट इज पी, बेसिकली अगर लंग हमारे कोलैप्स कर जाएंगे, जैसे अगर गुब्बारा कोलैप्स है तो फुलाने में बहुत ज्यादा प्रेशर लगाना पड़ता है, एक ब्रेथ के बाद से अगर फूल गया तो अगली ब्रेथ को कम प्रेशर लगाना पड़ता है सेम वॉल्यूम डिलीवर करने के लिए। यही गुब्बारे वाला फंडा यहाँ पे है। अगर हमने पीप को यहाँ पे सेट कर दिया तो यहाँ के बाद से लंग से एयर बाहर नहीं आएगी, लेकिन अगर हम थोड़ा सा भी 4 का प्रेशर देंगे तो वॉल्यूम ज्यादा इंक्रीज करेगा। दिस इज नोन एज द कंप्लायंट पार्ट ऑफ द लंग एंड दिस इज नोन एज लोअर इनसफिशिएंट पॉइंट। और फ्रेंड एक चीज और आप देखिए यहाँ पे, यहाँ से अगर हम प्रेशर बढ़ाते हैं यहाँ से यहाँ तक 1.5 सेंटीमीटर, तो वॉल्यूम कितना बढ़ा, लगभग 0.5 सेंटीमीटर के आसपास का वॉल्यूम बढ़ा। तो इतने पे बहुत कम, दिस इज नोन एज बीकिंग इफेक्ट और दिस इज नोन एज अपर इनसफिशिएंट पॉइंट। तो आवर लंग शुड बी लाई बिटवीन लोअर इनसफिशिएंट पॉइंट वेयर पीप शुड बी सेट और अपर इनसफिशिएंट पॉइंट जहां पे हम पीआईपी को सेट करते हैं, तो वी विल बी इन बेटर पार्ट ऑफ द वेंटिलेशन विदाउट मच एफर्ट। इन न्यूअर वेंटिलेटरी सेटिंग्स लाइक बीपीएल वेंटिलेटर अभी मैंने देखा था, उसमें दे आर telling you what is the upper insufficient point, what is the lower insufficient point, what is the compliant part of the lung, everything is calculated. Very high quality of the ventilators are there, but we can calculate by this also. How to optimize the ventilation? Tidal volume low or minute ventilation is low. अगर ये low है, what to do? हमारा प्रेशर मोड पे हम प्रेशर बढ़ा देंगे ट्यूबिंग में हर, लेकिन प्रेशर बढ़ाने से पहले सारे वेंटिलेटर और सारी ट्यूबिंग को हम चेक करेंगे, ठीक है। या दूसरा हो सकता है कि इतना खराब लंग हो कि हम उस प्रेशर पे उतना वॉल्यूम डिलीवर ही नहीं कर पा रहे हैं, तो हमारा लो आएगा। यहाँ पे एबीजी का काम आएगा कि आप अगर आप देख लीजिए एल्वियोलर आर्टेरियल ऑक्सीजन ग्रेडियंट या AaDO2 या रेशियो अगर हम देख लें तो बता देगा कि लंग्स आर वेरी बैड, हम इसके बियॉन्ड कुछ नहीं कर सकते। सडन राइज इन द पीक प्रेशर, अगर एकदम से बढ़ जाता है तो कई बार ट्यूब किंग कर जाती है, ट्यूब ब्लॉक हो जाती है या ब्रांकोस्पाज्म हो जाता है ड्यू टू सिक्रेशन। उस समय में हमें पेशेंट को स्पाज्म है तो नेबुलाइज करेंगे, सिक्रेशन है तो वी विल टेक आउट, किंग है तो सीधा कर देंगे एंड इंश्योर पेशेंट इज नॉट बाइटिंग द ट्यूब। टारगेट ब्लड गैस इज नॉट वेरी ऑप्टिमल ब्लड गैस, till date we are reading. pH can be tolerated between 7.3 to 7.5. PaO2 not between 72 or 70, 80 to 120. 55 is acceptable. PaCO2 45 से 55, बिल्कुल 35 लाने की कोई जरूरत नहीं है. लैक्टेट शुड बी लेस देन 4. ये मार्कर आप इन्फेक्शन भी होता है, शॉक होता है. इलेक्ट्रोलाइट शुड बी नॉर्मल. हाउ टू ऑप्टिमाइज द ब्लड गैस. यहाँ पे दो चीजें हैं. हम चाहते हैं एडिक्वेट ऑक्सीजन हो, मतलब SpO2 PO2 नॉर्मल हो और PCO2 नॉर्मल हो. लेकिन अगर लो PaO2 आ रहा है, ऑक्सीजन कम आ रही है, तो तीन चीजें हैं जो हम कर सकते हैं. 3-4 चीजें हैं. पहला, इंक्रीज द पीप. हम पीप को बढ़ा दें. पीप को बढ़ाने से क्या होगा, हमारा लंग्स और कंप्लायंट पार्ट में आ जाएगा, एरिया ऑफ वेंटिलेशन बढ़ जाएगा, तो ऑक्सीजनेशन बढ़ जाएगा. एक. दूसरा, आई होता है, आई डिटरमाइंस ऑक्सीजनेशन. हम आई को जितना बढ़ाएंगे ऑक्सीजन का लेवल उतना ही बढ़ेगा. बट ज्यादा बढ़ाने पे ई कम होता जाएगा, CO2 रिटेंशन होगा. तो वी हैव टू बी वेरी मच जुडिशियस इफ वी आर इंक्रीजिंग आई. तो पीप बढ़ा दिया, आई बढ़ा दिया. तीसरा है FiO2 बढ़ा ले, बट दिस इज ट्रांजिएंट. हम FiO2 ज्यादा देर तक बढ़ा के नहीं सकते, अदरवाइज फ्री रेडिकल इंजरी, ऑक्सीजन सुपर ऑक्साइड इंजरी स्टार्ट हो जाएगी. Fourth is that is change in the position. In neonate and smaller child, we are practicing here in Kanpur, but adult may it's very difficult. Theoretical was very easy, but in practical sense it was very difficult. But in neonate we are frequently doing that. We put the child in the prone position and put the head on one side and start ventilation. What it does, प्रोन पोजीशन से क्या होता है, एटिलेक्टेटिक पार्ट ऑफ द लंग होता है वो सब डायलेट कर जाता है. जो लंग कम वेंटिलेटेड है वो अच्छा वेंटिलेटेड होता है, धीरे धीरे ऑक्सीजन इंप्रूव करता है. बट इफ यू हैव प्रोन, चाइल्ड शुड बी इन गुड सिडेशन एंड आफ्टर एंड एटलीस्ट फॉर 12 to 16 आवर एट वन सेटिंग. तो ऑक्सीजन बढ़ाने के लिए पीप बढ़ाओ, आई बढ़ाओ, ऑक्सीजन बढ़ाओ और प्रोन कर सकते हैं. 4 चीजें हैं. हाई PaCO2 हाई है तो हमें कम करने के लिए वहां पे आई बढ़ा रहे थे, यहाँ पे हम ई बढ़ा देंगे, ई बढ़ा सकते हैं. दूसरा, अगर कहीं पे कोई ब्रोंकोस्पाज्म और कोई ट्यूब में किंक है, एक्सपिरेटरी वाल्व की प्रॉब्लम है, सिक्रीशन है, वो सब क्लीन कर देंगे. एंड हम रेस्पिरेटरी रेट बढ़ा सकते हैं, इससे वॉल्यूम ऑफ वेंटिलेशन बढ़ेगा तो हमारा CO2 वॉश आउट होगा. अलार्म, तो हमने अपने पेशेंट को प्रेशर सेटिंग पे रखा है, मतलब प्रेशर 21 से 22 से ज्यादा नहीं जाएगा. तो हम किसका अलार्म सेट करेंगे, हम टाइडल वॉल्यूम का अलार्म सेट करेंगे. हम चाहते हैं कि 180 ml रहे, लेकिन हम कभी नहीं चाहते हैं कि 4 ml पर kg 120 ml हो, 130 ml हो. तो हम लोअर लिमिट 130 ml सेट कर दिया और अपर लिमिट 6 to 8 ml पर kg है, तो 8×24 240. तो चलो हम 270-80 पे सेट कर दिए. तो ऊपर हमने 280 सेट कर दिया, नीचे हमने 140 पे सेट कर दिया. इसके बियॉन्ड जब भी वॉल्यूम जाएगा, ऊपर जाएगा तो हम PIP को कम करेंगे, नीचे जाएगा तो हम PIP को बढ़ाएंगे. तो अलार्म शुड बी सेट अकॉर्डिंग टू द मोड ऑफ द वेंटिलेटर एंड दिस इज वेरी इंपॉर्टेंट बिकॉज वी फॉरगेट टू सेट द अलार्म एंड व्हाट द सिस्टर्स आर डूइंग, दे गो एंड जस्ट स्विच ऑफ द अलार्म or they decrease the volume of the alarm and patient deteriorates and you people may not know कि my patient is deteriorating. So FiO2 peep like that, every alarm should be set. So what we have learned कि how to start the invasive ventilation in hypoxemic child. इन्वेजिव वेंटिलेशन को कैसे क्लिनिकली मॉनिटर करना है, कैसे हम ABG से मॉनिटर करेंगे एंड हाउ टू ऑप्टिमाइज द ऑक्सीजन एंड CO2 कंसिडरिंग ऑल द मॉनिटर्ड पैरामीटर. Thank you so much. Thank you. Any question?
Yes, Dr. Yashwant. There is a request to repeat the acceptable value slide.
Pardon?
Acceptable value slides.
अच्छा, ABG वाला ना?
Yeah.
ये वाला?
I think so.
Pardon, man?
Yes, that ABG.
I think acceptable part is our ABG कि भाई कितना ABG हम acceptable है हमारा. I think this one.
Yes, yes.
This is acceptable. It does not mean कि अगर आपके पेशेंट का 7.35 आ रहा है तो आप 7.3 करेंगे, नहीं. मतलब अगर 7.3 भी ABG आ रहा है तो you can continue the ventilation without changing any parameter. This is acceptable. अब 7.5 है, means कि pH is slightly towards alkalotic side. Don't do anything कि हम CO2 retention करा के pH कम करा दें, नहीं. This is acceptable. PaO2 55 जैसे SpO2 के लिए है कि 92 to 95 is acceptable. तो 92 पे हमारा PaO2 अगर 55 आ रहा है, don't increase the I increase or don't increase the FiO2, don't prone the child, because these are the parameters. When there is no option, then we should apply all of those parameters. So 55 to 80 PaO2 is acceptable.
Okay. Okay. Thank you, Dr. Yashwant. There is no more question related to your talk. So thank you for explaining everything so beautifully. Hello. Dr. Yashwant has beautifully explained us that how to set ventilator parameters and how to modify them according to the need of the patients. So now, fortunately, the child has improved and the child is fit for weaning and extubation. So this important point, Dr. Aisha Ahmed from AMU Aligarh is going to tell us that how to wean and extubate a child from ventilation. I welcome Dr. Aisha.
Thank you so much, Dr. Chandrakanta. So can you hear me and can you see the slides?
Yes,
everyone?
yes,
Okay.
yes.
So welcome all in this post-lunch and last talk of the day. So as ma'am has very rightly said that till now you have been, we had sessions on how to put a child on mechanical ventilator and how to monitor such children. So now in this talk, I will try to cover certain aspects on how to decide about taking a child off mechanical ventilation. That is how to wean a child from ventilatory support and what is extubation. So the learning objectives of this session would be to understand the goals of weaning from mechanical ventilation. So the specific learning objectives would be at the end of the session, I want all of you should be aware of and have some idea about the physiological concepts behind weaning and extubation in children and how to test for readiness, how to decide and how to go about checking that this child is ready and can be weaned off ventilator, and to learn the entire process which is involved in successfully weaning a child from mechanical ventilator. So the overview, I would like to cover the objectives. I will try to cover using the following headlines, the definition, that is what classifies what is actually mechanical weaning from mechanical ventilation and what is extubation, what are the underlying principles behind it, what are the physiological aspects, how do you test for what is readiness and how do you test for readiness for a successful weaning and extubation, what is the entire process, and what is failure and what do you do when a child fails, when you fail to extubate a child from a ventilator. So coming to the definition, so weaning is not a one-step or two-step process. Like you put a child on ventilator and the child continues on mechanical ventilation for some time. So weaning is a whole process. It is not something that you push or you make certain changes or you push one button and then you can successfully extubate the child and call it he is off mechanical ventilation. But it is a continuous process, or rather I would say it is a transition where you shift a patient who is on total ventilatory support to a person who is breathing spontaneously on his own. And the important point here is gradually withdrawing positive pressure support. So this is important, that you put a child on ventilators and during the process of weaning, it is a whole process where you gradually bring down the ventilatory parameters, give the patient a child the time to recover, and gradually you switch him from spontaneous total mechanical ventilatory support to spontaneous mode of ventilation. So this is what weaning is all about. It is a gradual process and it is a transition phase, whereas extubation is one step. You can call it, it is nearly end step of a successful weaning, where you take the endotracheal tube out. So this taking the tube out is extubation, whereas weaning is the whole process of this transition. So the pictorial description, if you consider this mechanical ventilation as a journey, so throughout a child's mechanical ventilation phase, so as you can see, weaning has its own phase, it has got its own course. So it starts when you take a decision. So when a child is sick, obviously he has been put on a mechanical ventilator. Then there comes a time when you feel that the child deems fit and he can be now weaned off ventilator. You can give a trial. So there is then and there where weaning starts. So this heralds the onset of weaning, and this process continues where you subsequently decrease the ventilatory support and you check whether the child is accepting that or not, and gradually extubation is the end result. Okay, when you take this endotracheal tube out, but your job is not done then and there itself, because even after taking the tube out, the child may have complications, may have problems that he might be need to be put on mechanical ventilator again. So even the next 48 hours are also crucial. So it's a whole process where it starts, you start weaning, you monitor certain, I'll come to it, you monitor certain parameters, then you finally you extubate the patient if everything goes well, and for next 48 hours, look whether there are any chances of weaning failure or not. Okay, so this is what weaning is all about. And as you can see here, it accounts. So it's not something not something which is not that important, because as you can see, it contributes to almost the same duration of time as compared to the total journey of mechanical ventilation. So jitna time आपको बच्चे को वेंटिलेटर पे रखने में लगता है, ऑलमोस्ट उतना ही टाइम आपको बच्चे को सक्सेसफुली बीन करने के लिए लगता है, इफ यू वांट इट टू बी सक्सेसफुल. ठीक है, अदरवाइज you might fail and the child may require to be put on a ventilator again. So coming to the physiological aspects, so basically just understand that it's a optimum balance between respiratory load versus respiratory capacity. So respiratory load means the hurdles or obstacles against which the child is fighting. So that has what is the ventilatory system, the respiratory system of the child is like, uski compliance kya hai, resistance kaisi hai, and also the non-respiratory contributory factors like cardiovascular status kaisa hai, how the child's chest wall is doing. So all those hurdles, all those load against which the child is bearing. And as compared to the respiratory capacity, that means the overlying control hai of the central neurons, how intact his cognition, how intact his nervous system is to take control of the respiration. So breathing jo hai, in dono ke beech ka there is a optimum balance, or slightly it's tilted towards the capacity. That means कि respiratory load अगर थोड़ा बहुत compromise भी होता है, the child has got say poor compliance, या अगर उसका parenchymal involvement हो गया है, bronchospasm हो गया है, तो still if he has a good respiratory capacity, if he has good control, so he can manage. This is called endurance capacity. So till a certain period जो endurance होती है, that can be compensated and the child can maintain adequate ventilation. But अगर respiratory load की तरफ this balance is switched, so what happens? The child's respiratory drive does not become effective. So he cannot maintain and sustain ventilation on his own, and he requires support from a ventilator in that aspect. So there has to be a very optimum balance for appropriate oxygenation and ventilation and breathing to take place. So again, this is a description of the same thing. So if you consider this mechanical ventilation to spontaneous breathing as a whole spectrum during a child's breathing, so as you can see here, a child who is in total support, that means his demands are very high and the capabilities are low. अब capabilities low का reason can be he has got some central nervous system involvement, neural drive जहाँ पर effect हो गई है, or he has weakness in the muscle function, okay, और endurance जो है वो कम हो गई है, and the child's demands are more because of his involvement of the respiratory system, so demands are more. So this child is requires total support, जहाँ पर आपको पूरा support mechanical ventilation से देना पड़ेगा, and the child is not doing any part for sustaining his breathing. Vis-a-vis, if you go to the opposite extreme, where as the condition improves, धीरे धीरे करके the child's जो endurance है, this is improving, his capabilities are recovering, so the child gradually shifts into a total spontaneous mode. So this is how you have to judge. This is your job to judge when the child has shifted and switched from a total support and he has got a normal reserve. This is the time when you can think about weaning and you can switch the child from mechanical ventilation to spontaneous ventilation. So this is what you are supposed to learn and look for in a child who has been ventilated. So basically weaning, as I said, is a whole process. So it has got phases. So it starts with pre-weaning. Once you take decision, a bacha is doing fine and we have to think about weaning this child. So there are certain prerequisites, which constitutes the pre-weaning phase, followed by spontaneous breathing trial. So this is one parameter or one maneuver which you do just to check whether this child is fit to be successfully weaned off or not, followed by extubation. ठीक है, तो सबसे पहले आप कुछ तैयारियां करते हैं, फिर आप उसको एक ट्रायल देते हैं जस्ट टू चेक कि ये बच्चा सही से वीन हो पाएगा कि नहीं. फिर जब एवरीथिंग गोज वेल, फिर आप ट्यूब आउट करते हैं एंड देन यू मॉनिटर द चाइल्ड whether he does not develop any post-weaning acute complications. Okay. So when to wean, कैसे wean करना, कब हम decide करेंगे? So obviously and most important point is underlying disease process improving. As you can see here कि जिस भी condition की वजह से आपने उसको intubate किया था और ventilator पे रखा था, so the most important parameter and prerequisite is that process either is improving or has improved. So definitely जो parameter था, जो criteria था for which the child had to be put on ventilator, that has been dealt with nicely. And the child and other parameters are appropriate oxygenation. There are certain parameters that the child's oxygenation is appropriate. He has got adequate ventilation. There is absence of any major organ system failure, and the child has got intact airway protective mechanism. Okay, so अगर ये parameters होते हैं, only then you can think about starting this process of weaning. So subjectively, आप कैसे कहेंगे what is appropriate level of oxygenation? So this is called readiness to wean. ये सारे parameters हैं. This child is giving you signs of he is ready to be weaned off. So appropriate level of oxygenation, what is that? If PaO2 is more than 60 millimeters of mercury, the child is maintaining oxygenation on less than 40% of FiO2, and the PEEP is less than 5 centimeters. So these are subjective values when you can think about readiness to wean. And adequate ventilatory status. What does that mean? The child is not in distress. He does not have tachypnea. He has respiratory rate which is normal for his age, and he has PaCO2 और जो ABG के जो parameters हैं जो आपने last session में भी discuss हुए थे, he is maintaining those in the normal range. His dead volume space to tidal volume space is less than 60%. That means he is now showing certain features of improvement. So now you can think about weaning him off. He has got functional respiratory muscles. His muscles are doing absolutely fine and has a good ventilatory drive. और जो protective mechanism है like gag reflex or cough reflex वो आ गए हैं. He is able to tolerate the suctions and secretions well. Only then you can think about weaning. Other parameters जो पहले हमने बात की थी, absence of major organ system. ठीक है, तो primary pathology should have been corrected, and also there should be absence of major organ system. Like there should be no evidence of cardiac dysfunction, myocarditis, या arrhythmia है, या fluid overload है. All these things should be taken care of. अगर आप चाहते हैं कि weaning should be proper. अगर if you don't take care of these parameters now, so the child might fail once you तो premature weaning कर देंगे, and there are chances of a weaning failure in that situation. He should be able to maintain normal temperature क्योंकि जितना ज़्यादा temperature high होगा, oxygen consumption उतना ज़्यादा होता है. So you have to take care कि underlying dyselectrolytemia नहीं होना चाहिए, especially potassium, magnesium, phosphate, क्योंकि ये सारे parameters, if you don't check them and you don't rectify them before going for weaning, so you might encounter a failure here. He should have adequate nutrition status, feeding start हो गई हो, and he has absolutely normal. All the organ systems should be functioning normally for a successful weaning to take place. And intact airway protective mechanism. What does that mean? He has appropriate level of consciousness. इतना तो उसका sensorium हो कि he can sustain breathing कि अपने आप से ब्रीथ कर सके, तभी तो आप उसको एक्सट्यूबेट करेंगे और वीन ऑफ करेंगे. He has intact cough reflex, as I said, कि cough कर सकता हो, gag reflex हो, so that aspirate ना कर ले secretions को, and he is cooperative. He understands. He is coherent enough to breathe on his own. So these are the subjective parameters when you test subject the child to further process. जो आपने हमने process start की थी, तो जब ये सारे parameters meet करेगा कोई भी बच्चा, this means कि अब हम बच्चे को next step पर ले जाएंगे, and we have good signs. So next step is spontaneous breathing trial. So as the name implies, इसमें हम उसको एक trial देते हैं. You cannot put the child off ventilator all of a sudden. तो हम एक procedure करते हैं which is called spontaneous breathing trial. So what do you do in that? थोड़े time के लिए you put the child on either TPs या CPAP with a 5 centimeters of water. So what do you do in that spontaneous breathing trial? कि इसमें आप trial देते हैं where you put the child on this modes, TPs और CPAP से देते हैं और gradually इसका time increase करते हैं. And then you see whether the child is able to tolerate this trial or not. ठीक है, gradually आपने time increase किया, night time rest देते हैं, morning hours में increase the gradually increase the duration. And if the child is जो है passing this SBT, that means he is not showing any parameters of distress, any parameters which constitute a failure of SBT, then you can always think about putting the child and giving him a trial of extubation. So this is a weaning modality जहाँ पर आप spontaneous breathing trial देते हैं and you just wait and see whether the child develops any subjective parameters or not. तो क्या parameters हम देखते हैं जब हम बच्चे को SBT पे shift करते हैं? So there are certain objective criteria and there are certain subjective criteria. So what constitutes objective criteria? You have to look for any alteration in the respiratory rate or heart rate. So tachypnea, tachycardia, hypotension, any acidosis, arrhythmia, अगर ये सारी चीजें develop हो रही हैं, या subjective criteria like diaphoresis, अगर आपको लग रहा है increase distress हो रहा है, the child is becoming more agitated, बहुत ही restless हो रहा है, nasal flaring, grunting, any abnormality, मतलब कोई भी आपको criteria मिल रहा है, तो you should abort this SBT then and there. फौरन आपको abort करना है and you have to put the child back on ventilator. This means कि आपका trial fail हो गया है, so that means perhaps we were too premature, हमने timely थोड़ा पहले कर दिया, and then you have to recheck. फिर आप देखिए कि there is something, perhaps the primary pathology has not been taken care of, perhaps भी अभी बच्चे का जो है वो respiratory system पूरी तरह recover नहीं हुआ था, उसका oxygenation proper नहीं था, perhaps उसका अभी dyselectrolytemia correct नहीं हुआ है. So you have to check for causes, but आपको ये SBT abort करना होगा and the child has to be switched back again to the ventilator on the same setting. जिस setting पे आपने trial लिया था उसी settings पे डाल देंगे. And another thing which you need to remember here is कि आप अगर once a child fails SBT, so you have to look for causes. और जो next आप trial देते हैं, you should not give it within 24 hours. ठीक है, तो next trial के लिए you should wait for at least 24 hours and you should look for causes. क्या चीजें हो सकती हैं that child failed this SBT, and next day after 24 hours you can give another trial of SBT provided you have taken care of all the prerequisites जिनकी हमने पहले बात की थी. So all those prerequisites have been met, then you can always go for a second trial of SBT. So weaning successful, आपने trial दिया. So what constitutes as a successful weaning? जिसे हम कहते हैं absence of ventilatory support 48 hours following the extubation. आपने SBT दिया, बच्चे ने tolerate किया, फिर आपने decide किया weaning mode पर डाला, and then you extubate the child. फिर as I said, your job doesn't end there. फिर next 48 hours are very crucial. तो next 48 hours में आपको फिर से देखना होता है कि ये सारे parameters तो नहीं develop हो रहे हैं, distress, tachycardia, tachypnea, so that the child does not require to be re-ventilated. अगर नहीं है, तो you call that successful. You have been successful in your weaning, whereas failure is either your SBT fails, जो हमने parameters की बात की थी, and the child requires to be reintubated. ऐसा कई बार होता है कि आप extubate करके you are very happy, but आपको evening में खबर मिलती है the child had to be put back on ventilator. So this is what ventilatory failure. इसीलिए it's very difficult to understand, क्योंकि अगर आप timely करेंगे weaning, so the chances of failure are always less. So there are two ways हम कैसे wean करते हैं. So there are two schools of thought. एक है जो slow traditional method है और another is rapid modern method. So slow traditional method क्या कहता है? जो पुराने जो intensivist और clinician है, they are more fond of this method, जहाँ पर वो weaning slow करते हैं. ठीक है, so what happens that और especially ये किन conditions में जो है it's useful where there is a case of prolonged ventilation. For whatever the reason, the child has been put on ventilator for quite a long period of time, और जो disease pathology slow है, like in pump failure, like in multi-organ system failure, तो gradually, तो weaning is more gradual. आप धीरे-धीरे सारे ventilatory parameters कम करते हैं और gradually आप बच्चे को wean off करते हैं, so that you do not encounter a failure. And as compared to rapid modern method, what is this method? जो conditions, there are certain conditions जहाँ पर आपने बच्चे को intubate किया होगा, but that is for a very short period of time. Like especially आपने asthmatics में देखा होगा कि जहाँ पर बहुत ही severe spasm होता है, बच्चे को ventilate करने की जरूरत पड़ती है, but recovery बहुत अच्छी होती है. So all those conditions where the recovery is good and child has been put on ventilator for a smaller duration of time, and conditions which are quickly reversible, just as you can see a shock without multi-organ system failure, and you have post-operative stabilization. Post-op है, बच्चे को initially stabilize करने के लिए ventilator पे रखा है, तो उधर आप rapidly, that means कि आप बच्चे को wean करेंगे, लेकिन सारे parameters बहुत ही shorter duration में आप उसको, and with monitoring of the clinical signs and symptoms. ठीक है, बच्चे को आप मॉनिटर करेंगे, एंड दैट डिपेंड्स अपॉन जो फिजिशियन है, ट्रीटिंग फिजिशियन डिस्क्रिप्शन एज वेल, कि आप बच्चे को मॉनिटर करते हैं, लेकिन कंडीशन क्योंकि बहुत शॉर्ट थी, द चाइल्ड हैज शोन अ वेरी गुड रिकवरी, तो वीनिंग यू कैन डू इन अ शॉर्टर पीरियड ऑफ टाइम. एंड इन अ ट्रेडिशनल मेथड व्हाट हैपेंस कि आप उसको ग्रेजुअली धीरे धीरे करके बच्चे को जो है वीन ऑफ करते हैं फ्रॉम वेंटिलेटर. सो व्हाट इज द अंडरलाइंग बेसिस, व्हाई दिस ट्रेडिशनल एंड व्हाई दिस मॉडर्न अप्रोच? सो व्हाई ट्रेडिशनल? फुल प्रूफ है, टाइम टेस्टेड है, बहुत ही स्लो कर रहे हैं, तो इसमें कॉशियस अप्रोच है, क्योंकि आप इतनी धीरे धीरे कर रहे हैं और साथ में बच्चे को मॉनिटर कर रहे हैं, हर चीज आप चेक कर रहे हैं. सो द चांसेस ऑफ फेलियर आर लेस, फेल्ड एक्सट्यूबेशन के चांसेस कम होते हैं. बट व्हाट कैन बी द इश्यूज विद दैट? इट इंक्रीजेस मोर्टालिटी, मोर्बिडिटी एंड कॉस्ट. जितने टाइम आप वेंटिलेटर पे, तो इट्स नॉट फ्री ऑफ कॉस्ट, तो जो लॉजिस्टिक्स इन्वॉल्व है, तो इट एड्स टू द कॉस्ट एंड इट एड्स टू द मोर्बिडिटी. वेंटिलेशन भी जो है वो मैकेनिकल वेंटिलेशन फ्री नहीं होता ऑफ साइड इफेक्ट्स. कितने सारे वेंटिलेटर एसोसिएटेड निमोनियाज हो सकते हैं, ट्रॉमा हो सकता है. ओके, सो और प्रोलॉन्ग सेडेशन पे आपको बच्चे को रखना पड़ता है. सो ट्रेडिशनल अप्रोच के दीज आर द ड्रॉबैक्स. सो व्हाई मॉडर्न अप्रोच? मॉडर्न अप्रोच क्यों इन्वोक हुई, क्यों एवरीबडी, सम पीपल आर फॉलोइंग मॉडर्न अप्रोच? बिकॉज दिस जो भी पीडियाट्रिशियंस आपने, आई एम श्योर आपका भी ऑब्जर्वेशन होगा कि अबाउट हाफ ऑफ द चिल्ड्रन वी हैव सीन इन द वार्ड्स के बच्चों को हम इंक्यूबेट करते हैं, थोड़ा सा ही बेटर होता है, बच्चा कॉन्शियस होता है, हाथ पांव चलाया और जो है वो ट्यूब आउट हो गई. कितना कॉमन सिचुएशन होता है कि बच्चे ने खुद से ट्यूब निकाल दी, ही बिकेम वेरी एक्टिव, और उसके बाद ही इज मेंटेनिंग, ही डज नॉट रिक्वायर एनी इंटरवेंशन. सो परहैप्स दैट मेड द क्लिनिशियंस एंड रिसर्चर्स थिंक कि ऐसा मे बी परहैप्स वी वर ओवर वेंटिलेटिंग या वेंटिलेट कर रहे थे फॉर अ लॉन्गर ड्यूरेशन, दे डिड नॉट रिक्वायर, क्योंकि उसमें से कितने सारे ऐसे हैं जिनको आपको बाद में इंट्यूबेट नहीं करना पड़ता है. सो दैट इज द रैशनल बिहाइंड मॉडर्न अप्रोच, कि अगर quick recovery है और disease, so that depends upon the condition for which the child was put on ventilator. ठीक है, अगर आपको लग रहा है asthma का है, बच्चा ठीक हो गया, ये post op है, the child is doing fine, then you can always go for modern approach, जहाँ पर आप quickly उसको जो है वो wean off कर देते हैं ventilator. Because if you go by books, अगर आप सारे parameters करेंगे, तो बहुत से बच्चे हैं जो clinically आपको ठीक लग रहे होते हैं, but objectively they are not following the criteria, but you can wean them off very nicely. Then there are certain predictors, जैसे हमारे पास ICU settings में स्पेशली हर चीज के indices होते हैं, वैसे we have certain predictors which can help you in aiding your decision to wean a child. ठीक है, तो कुछ predictors like rapid shallow breathing index, like crop index, leak test. तो इसमें आप क्या करते हैं कि rapid shallow breathing index में that depends upon the ventilatory, the respiratory rate and tidal volume, और ये weight के base पे एक index calculate किया जाता है. Like crop index, ये भी pulmonary dynamics, PaO2 and P capital alveolar and arteriolar PaO2 के basis पे आप indices calculate करते हैं, and इनके basis पे you can predict कि कौन से बच्चे हैं जो कि आपके weaning को successfully pass करेंगे, या कौन से बच्चे हैं जो fail कर सकते हैं. But these are not very sensitive and specific. तो ये आपको help कर सकते हैं, but आपका decision जो clinical parameters हैं, those are more important. तो ये predictors हैं, you can use them because they can act as a aid in your decision. ठीक है, like dead space fraction है, जितना dead space fraction कम हो रहा है, that means उसकी recovery अच्छी हो रही है. Like leak test, so what do you do in leak test? इसमें आप inspiratory जो air pressure है 15 to 20 centimeters of water से देते हैं, उसके बाद you check larynx के ऊपर कि air flow हो रही है कि नहीं. So that tells you about कि सब जो laryngeal जो edema है वो कितना है, कितनी recovery हो गई है. But none of these tests are infallible. तो आप 100% you cannot rely upon those, but they can just help you in corroborating your decision. So what are the steps? तो हमने अब decide कर लिया the child has passed SBT. Now we have thought कि अब हम इसको और monitor करके और finally हम इसको extubate ही कर देंगे. So you have to taper or stop sedation. ठीक है, अगर longer acting drugs हैं तो आपको short acting पे करना है, and you have to taper, क्योंकि as I said कि आपको जो respiratory capacity, जो drive है, that should be optimum. जब तक बच्चे में drive नहीं होगी, उसका CNS इंटैक्ट नहीं होगा, वेंटिलेटरी सिस्टम को और वेंटिलेशन को सपोर्ट करने के लिए, तो यू शुड नेवर अटेम्प्ट वीनिंग इन दोज चिल्ड्रन। तो आपको सिडेशन टेपर करना होगा एंड यू हैव टू सी कि बच्चा बिल्कुल कॉन्शियस हो गया है, इज कोहेरेंट, ही हैज गुड मसल पावर, मसल जो है इवन वेंटिलेटरी मसल्स जो है, चेस्ट वॉल मसल्स हैं, डायफ्राम है, एवरीथिंग इज परफेक्टली नॉर्मल और सही से वो अपना वेंटिलेशन सस्टेन कर सकता है जब आप वेंटिलेटर ऑफ करेंगे। एंड ही इज एबल टू सॉलो, कॉफ रिफ्लेक्स आ गया, गैग रिफ्लेक्स आ गया, ये सारी चीजें आपको चेक करनी होगी। सो देयर इज अ चेकलिस्ट व्हिच यू हैव टू इंश्योर बिफोर यू subject the child to weaning. फिर क्या है, you have to assess for peritubal leak that I was talking about. तो roughly 20-25 centimeters of water से लीक सुन जानी चाहिए। अगर और ज्यादा लग रहा है तो that means कि edema है। And some clinicians they prefer to wait, but that depends upon what other parameters are there. Then you have to decrease ventilatory support as tolerated. ठीक है, टॉलरेटेड मतलब हमने सारे ऑब्जेक्टिव और सब्जेक्टिव पैरामीटर्स की जो पहले बात की थी, तो धीरे धीरे करके जो भी उसका FiO2 है, PiO2, धीरे धीरे करके आप ग्रेजुअल करके कम करते हैं। और इन द मीन टाइम यू कीप मॉनिटरिंग द चाइल्ड कि उसमें कहीं कोई डिस्ट्रेस के ऑब्जेक्टिव पैरामीटर्स, टेकिकार्डिया, टेकिपनिया, सारी चीजें डेवलप हो रही हैं कि नहीं। अगर हो रही हैं, डोंट थिंक अबाउट एनीथिंग, फौरन दोबारा वेंटिलेटर पे डालिए, 24 आवर्स के बाद दोबारा ट्रायल कीजिए। अगर नहीं हो रही है, देन यू प्रोसीड टू द नेक्स्ट स्टेप। ओके, so this is how, so what are the different modes of weaning, किन मोड से हम weaning कर सकते हैं। SIMV आई एम श्योर सबने पढ़ा होगा, सिंक्रोनाइज इंटरमिटेंट मैंडेटरी वेंटिलेशन, फिर हम प्रेशर सपोर्ट से कर सकते हैं और हम TP से weaning कर सकते हैं। so कैसे करते हैं हम इनको। so coming to the SIMV का मतलब ही है सिंक्रोनाइज इंटरमिटेंट मैंडेटरी वेंटिलेशन। तो ये सिंक्रोनाइज करता है, पेशेंट रिकवर कर रहा है तो थोड़ी थोड़ी उसकी अपनी ब्रेथ्स आना शुरू हुई है स्पॉन्टेनियस, तो उन स्पॉन्टेनियस ब्रेथ को आप ऑगमेंट करते हैं विद मैंडेटरी वेंटिलेशन। ठीक है, तो कुछ बच्चे को अपनी ब्रेथ अपने आप स्पॉन्टेनियसली करता है और कुछ वेंटिलेटर देता है, सो दैट द चाइल्ड गेट्स टाइम टू रिकवर। और चाइल्ड का जो लंग होता है गेट्स टाइम टू रिकवर, उसको रेस्ट मिलता है, गेट्स टाइम टू रिकवर। फिर धीरे धीरे ग्रेजुअली जो आप इंटरमिटेंट जो मैंडेटरी वेंटिलेशन है उसका रेट कम करते चले जाते हैं और स्पॉन्टेनियस का बढ़ाते जाते हैं, सो दैट द चाइल्ड हैज टाइम टू रिकवर एंड यू कैन सक्सेसफुली वीन द चाइल्ड आउट। ठीक है, तो इट्स अ वेरी कॉमन प्रैक्टिस, SIMV मोड पे कर देते हैं, इसका मतलब दैट्स अ गुड साइन कि बच्चा टॉलरेट कर रहा है। फिर एज यू कैन रीड फ्रॉम हियर, ग्रेजुअली स्टेप्स ऑफ 1 और 2 ब्रेथ्स को आप कम करते चले जाते हैं और स्पॉन्टेनियस बढ़ाते जाते हैं, फिर आप बच्चे को फाइनली एक्सट्यूबेट कर देते हैं। देन अनदर वे इज द प्रेशर सपोर्ट। अगेन इसमें आप हाई प्रेशर्स देते हैं, यूजुअली 7 to 8 सेंटीमीटर्स ऑफ वाटर, और धीरे धीरे करके प्रेशर सपोर्ट को कम करते जाते हैं along with monitoring the child for development of any distress, any objective or subjective parameter। और जब बिल्कुल लो लेवल पे आ जाता है, then the next step is to extubate the child। T-piece meaning, T-piece जैसे आप देख रहे हैं इसका शेप T-piece की तरह ही होता है, T की तरह होता है। You put it on the endotracheal tube और आप spontaneous mode पे सेट कर देते हैं, 5 to 6 सेंटीमीटर्स ऑफ वाटर का आप उसमें CPAP देते हैं। फिर धीरे धीरे ग्रेजुअली आप फिर वही चीज जो हमने SPT के लिए की थी, आप चेक करते हैं कि बच्चा कैसे टॉलरेट कर रहा है, और if he is tolerating, that means he is doing fine and you can now successfully extubate the child। Role of tracheostomy। तो tracheostomy हम कब करते हैं, अगर आपको लग रहा है कि ये अगर ट्रांजिएंट फॉर आपको शॉर्ट टर्म के लिए आपने वेंटिलेट किया है, so it's not a good idea। जहां पर भी आपको लग रहा है कि this patient would require ventilatory support for some time, थोड़ा टाइम इसको रिकवरी में लगेगा, तो आप जो है वो उसको डेफिनेटली tracheostomy करते हैं। and it should always be done emergency procedure। ऐसा नहीं होता कि आप फौरन, you have to stabilize the child first। पहले आप उसको स्टेबलाइज कर दीजिए और उसके बाद फिर धीरे धीरे करके इफ यू फील कि दिस चाइल्ड इज गोइंग टू बी ऑन वेंटिलेटर फॉर लॉन्ग, तो फिर आप उसको ट्रेकियोस्टमी करते हैं। एंड जैसे हमने एक्सट्यूबेशन की बात की थी, एक्सट्यूबेशन इज द प्रोसेस ऑफ टेकिंग आउट द एंडोट्रेकियल ट्यूब। इसी तरह से फॉर टेकिंग अ ट्रेकियोस्टमी ट्यूब आउट वी कॉल दैट डीकैनुलेशन। ठीक है, तो इसका जो मीनिंग होता है दैट इज कॉल्ड डीकैनुलेशन, जहां पर आप ट्रेकियोस्टमी ट्यूब को आउट करते हैं। सो कमिंग टू द एक्सट्यूबेशन व्हिच इज द नॉट द लास्ट बट now that means कि we are nearing the end, कि हमने last step कर दिया है, we have extubated the child, आपने जो endotracheal tube को out कर दिया है, and दो सारे पैरामीटर जो हमने पहले बात की थी कि बच्चा he is able to tolerate, उसके सारे vital parameters normal हैं, he is able to take breaths on his own, coherent है, conscious है, then only you should take this decision। So why is that important? क्योंकि अगर आपने अर्ली कर दिया एक्सट्यूबेशन, सारे पैरामीटर्स मीट ही नहीं हुए थे और आपने रश कर दिया इन टेकिंग द ट्यूब आउट, सो द चांसेस ऑफ फेलियर आर हाई। फिर बच्चे में कुछ ना कुछ डिस्ट्रेस डेवलप होगा, सो दैट ही हैज टू बी शिफ्टेड टू द वेंटिलेटर बैक अगेन। देन द चांसेस ऑफ री-इंट्यूबेशन, मॉर्बिडिटी, मोर्टालिटी, एवरीथिंग इज हाई। ओके, एंड डिलेड का है, और अगर आपने डिलेड कर दिया कि अगर बैलेंस नहीं है कि आपका जो है वो आप अननेसेसरी उसको इंक्यूबेटेड रखे हुए, अगेन चांसेस ऑफ pneumonia, chances of trauma, prolonged ICU, cost, everything is going to add up to the host of a family. इसलिए it has to be very optimized and there has to be a very delicate balance कि कब आपको decide करना है कि the child has to be extubated. So what is readiness to extubation? किसे कहते हैं कि हम extubate करेंगे? So this is again a criteria कि extubate करना है. तो उसमें आपको क्या क्या चीजें देखनी है? एक हमने SBT तो देखा ही था, spontaneous breathing trial. बच्चा has passed that SBT. Then you have to look for certain parameters, जैसे बच्चे के vital signs. Everything should be within normal range, like normal age appropriate heart rate, respiratory rate, blood pressure, सब कुछ normal होना चाहिए. Minimal ventilatory settings पे he should be able to sustain a good oxygenation and ventilation, PEEP 5, FiO2 less than 40%, pressure support less than 10, और presence of endotracheal coupling. ठीक है, अब आपको है कि अब आप इस बच्चे को एक्सट्यूबेट कर सकते हैं because he is classifying and qualifying for all the criteria. तो आपको क्या करना होगा? स्टॉप फीड्स 6 hours prior और स्टॉप सेडेशन. आपको सेडेशन उसका स्टॉप करना होगा. सो कैसे आप करते हैं? सो देयर आर 2 ways, सेमी फाउलर्स, हाई फाउलर्स. उसमें आप सबसे पहले बच्चे को पहले एक्सप्लेन करते हैं बच्चे को और फैमिली को कि आप जो है आप एक्सट्यूबेशन आज अटेम्प्ट करने जा रहे हैं. बच्चा शुड बी कॉन्शियस, एज आई सेड, कोहेरेंट होना चाहिए. फिर आप उसको पहले प्री ऑक्सीजनेट करते हैं 100% ऑक्सीजन पे, और देन यू हैव टू सक्शन सो दैट अगर ऊपर कोई सिक्रीशंस हैं फेरिंग्स के ऊपर, सो दे हैव टू बी सक्ड आउट. तो सबसे पहले यू डू suctioning, a good suctioning. Then what do? You try to suction the and clear the airway as much as possible. Airway को बिल्कुल clean करते हैं. Suction should be very thorough and nicely done. उसके बाद resuscitation bag से उसको कुछ breaths देते हैं और high flow देते हैं, so that सारी secretions जो है वो above airway में, और उनको आप suction कर लें. फिर at the time of mid peak inspiration, ठीक है, जब बिल्कुल deep inspiration में होता है, then you can take the tube out. So this is how you do extubation in a child. तो जब आपने extubation कर दिया तो what should be done next? Administer the same fraction of oxygen as before extubation. तो आप शुरू में उसको कुछ टाइम के लिए FiO2 high flow देते हैं so that he is able to gradually जो है transition from बिल्कुल extubated के साथ एकदम से आपने tube out किया अपना spontaneous breathing पर आ जाए, और आप बच्चे को कहते हैं कि gently धीरे धीरे he have to take a deep breath, थोड़ा सा माइल्ड कॉफ कराने के, and you have to look whether the child does not land up into distress. और next few hours are very crucial क्योंकि इसी के अंदर chances होते हैं failure के, तो you have to monitor whether the child, और थोड़ा सा anxious भी होते हैं obviously because you have taken the tube out, so you have to provide solace and comfort to the family and the child per se. और best is कि अगर आप एक blood gas भी करके देख लें, everything is falling into place and the child is not landing up into failure. So going to algorithm, so this is the same thing कि पहले हमने mechanical ventilation किया, then we check for these parameters, अगर oxygenation, ventilatory status, absence of major organ failure, intact airway, then we give a trial of SBT. SBT अगर pass कर लेता है तो आप extubation plan करते हैं. अगर SBT fail करता है तो आप फिर recheck करते हैं कि there is something which has not been taken care of. To take care of that parameter, और फिर 24 hours के बाद आप दोबारा trial करते हैं. And again we have the same subjective and objective parameter जो हमको हमेशा हर patient पे देखने हैं, और अगर these parameters आ रहे हैं तो you have to put the patient back on mechanical ventilation. So what happens post extubation? ठीक है, अब आपने extubate कर दिया है, आप vitals देख रहे हैं, फिर non invasive जहाँ पे आपको लग रहा है कि high risk of failure है, condition ऐसी थी, बहुत time तक बच्चा intubated रहा था, तो फिर आपको थोड़ा non invasive intubation ventilation देना होता है for some time. Otherwise most of the patient, उनको अगर आप nasal prong से ही oxygen face mask से दे देते हैं, so they do tolerate and do well in the post extubation state. Close monitoring, as I said, क्योंकि 24 to 48 hours में ही you have some clue that this child is failing and he has to be switched back. Failure हो सकता है, तो आपको check करना है, distress, vitals, everything has to be checked how the child is failing. And non-invasive जो pressure ventilation है, it's beneficial because it has been proven to improve survival और mortality rate कम करता है, risk of infections और ICU stays को कम करता है. So if you feel this child has been on ventilator for quite some time and he might have failure or he might have issues, so you put him on non-invasive positive pressure ventilation. Again, like we have scoring system for many things, इसके लिए भी एक 2 score होता है, modified Wesley score, जिसमें आप based on inspiratory striders, air movement और retraction, इन सारी चीजों से check करते हैं कि whether the child can have problems after extubation or not. So the score, if it's equal or more than 4, तो आपको adrenaline से nebulize करना होता है. Again, these are all not very specific test, बस ये आपको एक aid होते हैं बट आपको क्लिनिकली बच्चे में पैरामीटर जो हमें सब्जेक्टिव ऑब्जेक्टिव दोज आर वेरी इंपॉर्टेंट, वो आपको हमेशा मॉनिटर करना होता है कि बच्चे का हीमोडायनेमिकली स्टेबल कैसा है, ऑक्सीजनेशन, ब्लड गैसेस कैसी हैं, सो दोज थिंग्स आर इंपॉर्टेंट. अगर इंस्पिरेटरी स्टाइडर हो गया है, रिट्रैक्शंस हो रहे हैं एंड एयर मूवमेंट इज लो, सो दैट अमाउंट्स टू स्कोर मोर देन 7, सो दैट मींस कि आपको बच्चे को दोबारा से वेंटिलेटर पे डालना होगा. So what complications can we have जब हमने इसको extubate कर दिया है? So most common seen in as many as about 1/4 of the children who have been extubated is the PEAO, that is post extubation airway obstruction. बहुत ही frequently होता है laryngeal जो edema की वजह से you can encounter child has distress and child has stridor and breathing difficulty. The reasons और किन बच्चों में ज्यादा होता है, तो it's said कि smaller age group में, और अगर आपने larger जो endotracheal tube डाल दी है for that age, ठीक है, मल्टीपल अटेम्प्ट्स हैं, एयरवे मैनिपुलेशंस बहुत हैं, सो ऑल दीज ऐड टू इंक्रीजिंग दिस इंसिडेंस ऑफ पीएओ. और कफ ट्यूब का देयर इज अ प्लस एंड माइनस. सो सम स्टडीज दे हैव सेड कि कफ ट्यूब से ज्यादा होता है, बट अदर्स हैव फेल्ड टू डेमोंस्ट्रेट कि दिस कफ ट्यूब कॉजेस मोर चांसेस ऑफ पीएओ. सो यू हैव टू लुक फॉर दैट. द मोस्ट इंपॉर्टेंट क्वेश्चन, रोल ऑफ स्टेरॉइड्स व्हिच ऑल ऑफ अस हैव बीन यूजिंग. स्टेरॉइड्स का क्या रोल होता है एक्सट्यूबेशन के लिए? सो अगेन देयर इज अ ग्रे एरिया, प्लस माइनस. फ्यू स्टडीज व्हिच से कि अगर आप पहले स्टेरॉइड दे देते हैं तो जो है वो सक्सेसफुल वीनिंग होती है, द आउटकम्स आर गुड. वेयर आर द सर्टेन स्टडीज व्हिच से इट डज नॉट मेक मच ऑफ अ डिफरेंस. सो व्हाट कोक्रेन डेटाबेस सेज कि there is not significant improvement if you get steroids. Okay, so it's on physician's discretion whether you want to prime the child or with steroids before extubating. अगर आपने किया है decide, तो at least it should be given at least 6 hours before planning extubation. ठीक है, तो 6 hours पहले से प्लान करके आप उसको डोज देना शुरू करते हैं. 6 hourly डोज देते हैं for 6 doses, and at least 6 hours के बाद after the first dose you think about taking the tube out. Otherwise plus minus role है. If you think that this child, again the same situation, if you think कि बहुत prolonged extubation रहा था, chances of PEAO are high, then you can think about giving the child corticosteroids before extubation. So what can be the complications? Immediately after taking the tube out, as I said, restlessness, agitation, normal भी होता है. So the child can have tachycardia, the child can have distress, the child can have high blood pressure for some time. आपको मॉनिटर करना होता है. थोड़ा सा बच्चा रिलैक्स होगा, डीप ब्रीदिंग करेगा, नॉर्मल ब्रीदिंग करेगा, then you have to see whether these things are persisting. That means की प्रॉब्लम है या these things are normal and the child is absolutely normal. Laryngeal edema, hemorrhage, trauma to the vocal cord, hoarseness of voice. So these things can persist for some time, and you have to monitor how the child is able to take that. So what factors can lead to extubation failure? अगर आपने premature कर दिया है, अगर respiratory mechanics जो हमने बात की थी, load की और capacity की, अगर that has not been taken care of, अगर बहुत टाइम तक आपने इंट्यूबेट कर दिया है, हीमोडायनेमिक अनस्टेबिलिटी है, एनीमिक है बच्चा, उसका न्यूट्रिशन स्टेटस कॉम्प्रोमाइज्ड है, अभी तक उसका गैग और कॉफ वापस नहीं आया था, he has certain genetic abnormalities, metabolic perturbations, इन सारी चीजों में आपको एक्सट्यूबेशन फेलियर के चांसेस हो सकते हैं. So always think and keep in mind that this thing is possible. I've got just 2-3 slides left. So this is a checklist. It has the same thing जो आप अपने PICU में बिल्कुल रख सकते हैं. इसमें सारी चीजें जो हमने बात की थी, तो ये सारी चीजें बस आपको टिक करना होता है. अगर ये सारे पैरामीटर्स जो है वो फॉलो कर रहा है बच्चा, सारी चीजें पॉजिटिव है, तभी आपको एक्सट्यूबेशन प्लान करना चाहिए. अदरवाइज यू विल. ओके, so take home message, this is the last slide. The goal for weaning from mechanical ventilation is to liberate the child. This is what I have been talking for almost 40 minutes now. So कोई successful ऐसा predictor नहीं है, सिर्फ aid है जो आपको help कर सकते हैं, definitive test नहीं है. And it is useful, this SBT, spontaneous breathing trial, is useful for assessing readiness to wean. अगर बच्चा पास करता है तो that means you can give him a trial of weaning. And SIMV, PSP and TPs are the common modes of weaning. So that is all I have to say, and thank you to all the contributors who put in their efforts to prepare this wonderful talk, and thank you all. Any questions?
Thank you, Dr. Aisha, for this excellent presentation, and there is 1 or 2 questions for you.
Apart from how much time is left and when is that ending?
So there is one question: after how much of time of intubation the tracheostomy should be done?
ऐसा कुछ टाइम नहीं होता. As I said, कि intubation that depends upon कि आपने किस इंडिकेशन के लिए इंट्यूबेट किया है. जैसे कॉमन सिनेरियो है कि पोस्ट ऑप केस है या फिर ब्रोंकियल एस्मा का है, जहाँ पे आपने शॉर्ट टाइम के लिए किया है, तो वहाँ तो डेफिनेटली लेकिन अगर आपको लग रहा है प्रोलॉन्ग्ड है, जैसे कि न्यूरोमस्कुलर इन्वॉल्वमेंट हो गया है, लाइक इन केसेस ऑफ सर्टेन जीबी सिंड्रोम, जहां पर भी आपको लगता है कि ये इंट्यूबेशन काफी टाइम के लिए आपको बच्चे को वेंटिलेटर पर रखना होगा, तो आपको डेफिनेटली प्लान करना होगा। ठीक है, इसका कोई टाइम नहीं है कि 48 आवर्स या 72 आवर्स, दैट डिपेंड्स अपॉन कि क्या कंडीशन है जिसकी वजह से आपने किया इसको।
Yes.
Okay.
So if it is required for more than 2 weeks, then definitely. And there is one more question: which steroid is best?
स्टेरॉइड के बारे में ही, इट्स नॉट डेक्सामेथासोन पे भी स्टडीज हैं, देयर आर फ्यू स्टडीज विच से डेक्सामेथासोन को उन्होंने बीटामेथासोन से और इवन प्रेडनिसोलोन से दे हैव कंपेयर्ड, सो दे से सम स्टडीज दे से कि देयर इज नो रोल, and some studies they say if you feel the chances of extubation failure are more, then you can give dexa.
Okay, so
6 hourly आप देते हैं.
Yes. So there is a question, I don't know what he wants to ask. Probably the full form of PEAO.
मैंने बताया था post extubation airway obstruction. ठीक है, I'll come to that. PEAO. पोस्ट एक्सट्यूबेशन एयरवे ऑब्स्ट्रक्शन. ठीक है, 25% केसेस में आपको मिल सकता है जहां पर एक्सट्यूबेट करने के बाद बच्चा फिर से ऑब्स्ट्रक्शन के फीचर शो करता है, PEAO. जहां पे प्रोबेबिलिटी हाई है, लाइक इन क्राइटेरिया में प्रोबेबिलिटी हाई हो सकती है, जहां पर आप एक्सट्यूबेट कर रहे हैं तो वहां पर आप स्टेरॉइड से प्राइम कर सकते हैं.
So can we use deflazacort?
Citing that, why not? अगर स्टेरॉइड का, सारे स्टेरॉइड्स का काम है, स्पेसिफिकली आई एम नॉट द बेस्ट पर्सन टू कमेंट अपॉन दैट कि डेफ्लाज़ाकोर्ट यूज कर सकते हैं कि नहीं, बट इफ यू कंसीडर स्टेरॉइड्स का रोल क्या होता है, एंटी इंफ्लेमेटरी होता है, तो डेफिनेटली इट शुड हेल्प, व्हाई नॉट? देयर इज नो रीजन ऑफ नॉट यूजिंग इट. एंटी इंफ्लेमेटरी है तो दैट विल डू इट्स जॉब, यू कैन.
And somebody has written TP's trial. I don't know what is the question actually. Question is not clear. The TP's trial.
I cannot see. I did not hear the question, ma'am. क्या है?
I don't know what is the question. Somebody has written TP's trial. So
TP's trial वही हुआ, spontaneous breathing trial में आप TPC, one of the modality जिसमें आप TPs और CPAP से चेक करके, TPs से आप CPAP देते हैं and you check that. TPs वही है, modality, winning modality है जिससे आप दे सकते हैं. उसको आप endotracheal ट्यूब से लगा कर फिर आप देखते हैं वही पैरामीटर जो हमने सब्जेक्टिव ऑब्जेक्टिव की बात की थी, कि whether the child is tolerating that or not tolerating. So that is a way, a means of giving weaning.
yeah. So thank you, Dr. Aisha. There is no more question to you.
Okay, thank you.
Thank you. And with this, we come to the end of today's session. Of course, this was very long, so thank you for staying with us. And I thank all the speakers for the excellent job. So today we end our session here, and tomorrow again we will meet at 12. So thank you all.
Okay, thank you.